Okay. Could you put on slideshow?
I have put slideshow.
Yes. Yes, it is coming. Can you change to the next slide? Yeah, it's working. Done. Perfect. Could you speak a little
No?
again?
Okay.
Yeah, everything is fine. Yeah. Done.
Are you able to hear me?
Yeah. It is fine. Thank you.
Okay.
You can stop.
Okay, thanks.
Good evening, everyone. I hope I'm audible and visible. So I thank everyone for joining the first CME, that is the on TB 101. So this CME today, as we all know, is the World TB Day in commemoration for Robert Koch for discovering or identifying the tuberculous bacilli. Okay, so let's start with the webinar. So first talk will be challenging cases of TB diagnosis, and this will be taken up by uh, two people. First, Dr. Yash Kathod, and then we followed by Dr. Saurabh Pandey. So Dr. Yash Kathod is a second-year DM ID resident in AIMS Jodhpur. Uh, so over to him now.
Am I audible to everyone? Am I audible everyone? So, I will start my presentation. Already we have some delay because of some technical issues.
એવું બની શકે એ બ્રીથિંગ એફર્ટ ના કરતા હોય એના લીધે તો એવું જ એ
Doctor,
નામ
a lot of
ઓફ થઈ ગયું નામ ધક્કા માર કરે છે.
Shall I start my presentation? Okay.
હા ભાઈ કોને સ્ટાર્ટ
Good evening to all, and welcome to this presentation. Happy Gangaur to all my colleagues. Those who are from Rajasthan, they know.
મારા મેં તો અવાજ નહીં આવે. ચાલુ છે.
Challenging cases of tuberculosis. What are the challenges we facing with the diagnosis? It's not a new topic. We know since always that the diagnosis of TB is quite challenging. It is not new that TB is kind of a masquerade. Just a minute. Okay. So I was telling about the challenges which we face during the diagnosis of tuberculosis. I think previous generation was lucky enough to understand the fact that TB diagnosis was not very difficult for them. They would just see the X-rays. They would just assume that there is a TB and they will start the treatment. Because more technologies are at our disposal. Onus lies on the ID clinician and clinician that microbiological evidence of TB be established at the end of the day. So it is not like that just by looking at the X-rays, we can start the treatment of tuberculosis, because not every X-ray finding denotes that the patient is infected with tuberculosis. Before starting my presentation, I would like to emphasize that how TB has always associated with human species. It has co-evolved with the human. Like ancestors of Mycobacterium were yes, sorry. So the tuberculosis, the ancestor of tuberculosis were infecting the ancestors of human beings. So as the human species evolved, the tuberculosis also evolved accordingly and with time. So much that the various species of tuberculosis are infecting the various races of the humans. They have some preponderance and they have some climate and temperature preponderance as well. Like India is a tropical country and we are highly affected by the, we should say, endemicity of the tuberculosis. Same, the Russia where it is temperate climate and quite cold Siberia, there also TB is very much a menace. The problem is that TB knows our body very well, and same, our body knows the tuberculosis very well. So sometimes they live in a very harmonious fashion, which we call it as a latent tuberculosis. Previously, this latent tuberculosis was not much of a problem. People used to die by 40, 50, 60. But now we have more of the life expectancy. With age, immunity diminishes, and this latent tuberculosis takes the active form. People are suffering from diabetes mellitus more often now than it was previously. And at elderly age, people might be affected by some malignancy. So we have to start some chemotherapy and immunotherapy, which can also lead to the reactivation of tuberculosis. So there are many articles and many serological studies which point out that the tuberculosis and humans are always the best partner, not friend, not parasite, but best partner at least since the inception of time. So being an ID clinician, I would like to emphasize that what are the major challenges which I face while treating our diagnosis of the tuberculosis. The first thing that it presents with quite a non-specific clinical signs and symptoms. As I told that tuberculosis and humans are coexisting. Since it is very much aware of our body situation and our body is aware of tuberculosis, there is a harmony and the presentation is rarely explosive. Most of the time it is insidious in onset and it can mimic many conditions, and we have to really work very hard to find the appropriate diagnosis at the end of the day. And when sometimes we do find the tuberculosis lying in our body, but we have to make sure whether it is a true pathogen or it is just a latent tuberculosis. If latent tuberculosis is there, we might not need to treat it unless we are planning for some immunosuppressive or chemotherapeutic agent. So I will discuss my case pertaining to that particular problem. Most of the tuberculosis, except for pulmonary tuberculosis, are possibly bacillary infection. So bacterial load is very low, and when we go for the diagnosis, we might not get the ample of sample to establish the microbiological evidence at the end of the day. It's a slow-growing organism, so turnaround time is also delayed. For that, the diagnosis is hinged for many days. And this tuberculosis, like we are prescribing many antibiotics for various conditions, like UTI is very common in female. And when we give levofloxacin, it will inadvertently be acting on the tuberculosis as well. So if there were any symptoms which were going to be presented in that case, would be suppressed because of those fluoroquinolones, antibiotics or something else. So that is also a common problem, that common antibiotics also acts against the tuberculosis bacteria. So all these things make the diagnosis of the tuberculosis very challenging. And sometimes when we do make the diagnosis on the retrospect, we may realize that we were not treating the first diagnosis properly, and it turns out to be the retrospective diagnosis. An adequate sampling issue, if extra-pulmonary TB is there, to retrieve the sample is really a task. We have to go and do some invasive procedure, and we have to take the sample from the right place in the right quantity to reach the diagnosis. So I will start with the case. She was 25-year-old female, bank executive from Bombay, quite from a high-profile society, influence society. She had history of on and off fever, which was high grade, which was associated with fatigue for past 1 month. So that is also a common thing that now, previously we used to think that tuberculosis was affecting more of the slum areas and not well-to-do families and poor people. But now it has, especially after COVID pandemic, it has come with a bang, and it is covering all of the population, at least in India. So these people are very educated and they are very apprehensive about their symptoms. When they finally reach to the diagnosis of tuberculosis, they are always shocked that how can we get the tuberculosis. So this was the main complaint. She had sore throat in the initial 1 week, which was relieved by some symptomatic medication. Associated symptoms include large joint arthralgia, which was more in lower limb than that of upper limb, which started for past 15 days. Few maculopapular rashes over trunk for past 3 to 4 days, and history of travel to Chennai 1 week before the onset of fever. History of stay at Kolkata for 4 years, and no there was no high-risk sexual encounter, no pets or animals exposure. So this was the presentation: high-grade fever, joint pain, arthralgia, initiated with sore throat. For above condition, since she was affected for past 1 month, she received some symptomatic treatment from some local doctors. Those doctors prescribed her with some common antibiotics, azithromycin. Some thought that it might be a non-resolving infection and tropical infection, so they also gave her some artesunate and doxycycline. With these treatments, she used to get relief for some 2 or 3 days, and symptoms used to reappear after that. When she presented to her, before that, she was taking ceftriaxone for 3 days, and unfortunately, she started having developed diarrhea, which was probably antibiotic-associated diarrhea, and she gave up finally, and she came to home and came to our hospital. Her home was at Jodhpur. So she traveled back to the Jodhpur from Bombay, and she was referred to our hospital. We admitted her, and we did the thorough general and systemic examination, which was quite unrevealing. Other than maculopapular rashes, we couldn't find anything. She was febrile, but there was no tenderness in the joints or something like arthritis, features of arthritis. By this time, we thought that we might find something in upper respiratory tract, but that was also not there. The upper respiratory tract was also fine. There was no condition at all. Since there was a prolonged fever, we thought that some differentials might be salmonellosis, viral, post-viral syndromes. We even thought of rheumatic fever and other tropical fevers. Since today's discussion is about tuberculosis, we know that the final diagnosis of this patient will be tuberculosis. But with this scenario, we were not really thinking about the tuberculosis in our patient because of so many reasons. There was no cough at all. If it was there, it was just for a few days, some dry cough, but nothing else. So we didn't think of tuberculosis as such. These were our most common first differential diagnosis. We did the baseline investigation. Other than anemia, everything was actually negative. So her TLC was within normal limits, and all urea creatinine were in normal limits. The one finding was a slight AG reversal, which was 3.75 albumin and 3.84 globulin. But yes, CRP and inflammatory markers were raised. And anemia, her anemia was more looking like to be anemia of chronic disease. Her TIBC and iron were low, but ferritin was on higher side. So we then thought that this is something else, not a common infection. Blood culture was also sterile, but as we know that she was already taking antibiotics for so long. So this was the basic profile we did for her. Everything turned out to be negative. at this point of time at our institute, we start labeling the patient to be the case of pyrexia of unknown origin. So we follow a very simple yet effective algorithm to reach to the diagnosis of pyrexia of unknown origin. The final etiological diagnosis. PUO is not a diagnosis, it is actually a lack of diagnosis. So what we do, we start with a simple history and physical examination and some baseline investigation. Even if the patient is having some baseline investigation from outside, we tend to repeat them in-house testing to see the trends and to cross-check the reports at first place. We try to find the diagnostic clues during our evaluation. We try to be as non-invasive as possible at the early stages of our evaluation. Since our patient was kind of clinically stable, she was febrile, but vitals were stable, and any of the signs and symptoms were not suggestive of red flag signs. So we started with simple history and baseline investigation. Then we proceed to some advanced stuff like radiography, CT angiography, PET-CT. We invariably do PET-CT for our patients presenting with PUO. If we do not find any evidence, we tend to go for invasive and higher technological tests like gene sequencing. So we try to save the money of the patient. We try to save the invasiveness for the patient. So that is a simple algorithm which we follow, and it is quite effective. We try to gather the diagnostic clues and we try to reach at the diagnosis. So we started with the investigation and some special investigation. We suspected that it may be infective endocarditis, though it was not even fulfilling the Duke's criteria. Echo was done, USG abdomen was done, they were fine. We did the rheumatological workup also, everything turned out to be negative. VDRL, ASLO titer was also sent, considering that it can be a case of rheumatic heart disease. We even did the herpes group of virus serology, that it may be post-viral syndrome. IgM was negative, so it kind of ruled out the post-viral syndromes in our patient. Radiography of joints, since large joint involvement was the chief complaint of our patient, those are also non-revealing. Then we did the CECD thorax and abdomen. In that, we find out there were some non-necrotic subcentimetric mediastinal lymph nodes, and our radiologists were of the opinion that they are more of reactive in origin rather than infective. But one interesting finding we found in our patient was some left renal vein thrombosis. With this, we thought that we must be missing something. There can be underlying malignancy or something else which we are missing. So anyway, we were about to go for PET-CT, and we did PET-CT in our case. Based on the PDC-based investigation, so there was thrombosis in the renal vein and subcentimetric lymphadenopathy in our patient in mediastinal area. We did the PET-CT. There were similar lymph node finding, but one thing, PET-CT, the nuclear medicine guy told us that those lymph nodes are necrotic in origin, and one lymph node, according to them, was more than 1 centimeter in size. So we did the thrombophilia profile to look for whatever the cause of thrombosis in this patient, in why this renal vein was involved. And other than that, PET-CT also revealed that there was thrombus in the pulmonary artery as well. So this patient has some hypercoagulative state and lymphadenopathy. Thrombophilia profile all turned negative other than APLA. Two antibodies, beta-2 microglobulin and cardiolipin antibodies, IgM, were positive in our patient. But our rheumatology team was of the opinion that this can be a false positive test. So they started the patient on anticoagulation, but they didn't establish the diagnosis of APLA syndrome. The patient is still like just 15 days in our follow-up. We are planning to repeat the APLA profile in our patient, but as of now, we have not certainly established the diagnosis of APLA. Since lymph node, necrotic lymph nodes were there, we did the sputum examination again. We previously did as well, but this time again we did the induced sputum examination. And at our center, we have come across this thing that if patient is having pulmonary TB, whether it is open or closed case, whatever it is, even with the atypical finding, if we do the gastric aspirate CG naught, many times it turns out to be positive. Like Pediatrician usually do this test in children because they are not able to spit out the cup. But in our setup, we do it regularly for the adult patient, and the results are really rewarding. It is kind of non-invasive test, but most of the time it turned out to be positive. So in this test also, we did overnight gastric aspirate, CBNAT and Zarin staining. Those were also negative. We have urinary histoplasma antigen test at our house, in-house setup. So we did that also because in our region of Western Rajasthan, we are seeing more and more cases of histoplasmosis, disseminated histoplasmosis. All those things turn out to be negative. So after exhausting with all the non-invasive and minimally invasive tests, we ultimately had to turn to the invasive procedure. We did consult our pulmonology department, and they got ready for the EBUS guided lymph node biopsy for this patient. But unfortunately, while the procedure, there was some complication. The patient landed up in the respiratory distress, and we had to abort the procedure. So that is the reason we have set the guidelines like that in our hospital and in our setup, that we should be starting from the non-invasive or minimally invasive test, and then we should proceed towards the more invasive test, because sometimes it can be fatal for the patient. We had to admit the patient in AICU. We stabilized the patient and we discharged her from the AICU. But because she was like a very high-spirited female, she said that I want my diagnosis no matter what. So she got agreed for the repeat procedure. Thanks to her, we did the repeat procedure on her, and we did retrieve the lymph node biopsy, which turned out to be Zanin stain positive. And it was CBNAR positive, but we detected the rifampicin resistance. So we established her to be the extra-pulmonary TB lymphadenopathy, tuberculosis lymphadenopathy with probably MDR resistant pattern. We did the LPA for that patient. It is like a standard as per our TB control program. It showed that the patient was also, the tuberculosis was also resistant to the high-dose isoniazid, and second line LPA showed that it was, the patient TB was resistant to the fluoroquinolones and second line injectable drugs. But fluoroquinolone resistance was not for high-dose moxifloxacin, or there is a gray area in the reporting of the LPA. So we were not sure that what kind of resistance for fluoroquinolone we are dealing with. So for time being, since she was febrile and she was suffering, we did start her on the long oral bedaquiline based therapy at the end. So after some 10-15 days of the therapy, the patient was subsided of the fever and she started improving well. Since we were in the dilemma that what kind of XDR-TB we are dealing with, so we are under the process of whole genome sequencing. Her report is due. We are expected to receive her report for whole genome sequencing of the sample within a day or two. Then we can decide what therapy we should give. Presently, we are giving the long oral therapy with the high-dose moxifloxacin. As of now, symptomatically, patient is improved, and we are still waiting for the whole genome sequencing, which will be available within a day or two. So ultimate diagnosis in this patient might reflect that she is a case of XDR-TB. But looking at the whole picture of the patient, I myself and my team, we are not very satisfied with our ultimate diagnosis. First of all, the case was quite an atypical presentation. There were no cough. Though she went to the Bombay, but Bombay is a some hotspot for the MDR and XDR-TB. That history is taken, but still, we were not sure that this was the TB presentation. This was not even our first differential. So it was the atypical presentation. We did find some underlying autoimmune condition in this case, and she may be a APLA syndrome positive patient. That remains to be seen in the future. So the question comes that whether the XDR-TB is just latent in our case, or it is the true cause of her symptoms. So though we find the bacteria, it might be just latently sitting over there. Since she is a XDR case, we didn't have any other option but to treat her. Nevertheless, she might be turning out to be positive for autoimmune profile also in the future. At that time, we will have to start her on steroids and some other immunomodulator drugs. So it is wise to treat her for XDR-TB as it is, because there are no guidelines regarding the latent XDR-TB as of now. So the question is whether this patient is a autoimmune case, autoimmune condition, suffering from some autoimmune condition, or whether it's a case of TB, or they are coexisting with each other. Might be the position that autoimmune condition might have reduced her immunity and she might have developed with XDR-TB. So this is a common lot which we face every day, what to do and how to proceed. But that is the reality of life, and we did start the treatment, and we are hoping some good result at the end of the day. So my take home message from this case and our presentation is that we should be mindful of atypical presentation. Atypical presentation can be TB, we know that, but obviously we should try to establish the diagnosis in the end as humanly possible. As algorithmic approach to the cases is always helpful. We save the money of the patient. See, PO cases, when they come, they have already spent their lot of money and time searching for the disease. The patients are really frustrated and exhausted. They are having some lack of patience. We have to explain them that if we are not able to find the disease might itself, the problem might itself resolve. So in many corporate setup, and because of the haste that many clinicians do, they perform all the tests altogether, and they do not reach the ultimate diagnosis. So algorithmic approach is the way to go. Invasive procedure we have to perform for the sake of the diagnosis, as in our case it was, though it was like a adverse effect of the invasive procedure, but we did so. I suppose it should be done in all the cases to establish the ultimate diagnosis. Ruling out the other underlying condition, if you are seeing the TB, it might not be the case. TB might be lying there in a form of latent infection, but we have to look for the other conditions so that we can decide upon the further therapy. So with that, I finish my case. Thank you.
Thank you, Dr. Yash, for very extensive and very discussing the very pertinent points regarding the diagnosis and why is it necessary to arrive at a diagnosis. And always PUOs are an enigma, which if all the ID physicians will have to deal with. So with that, we'll move to the next interesting case presentation, and for which I invite Dr. Saurabh Pandey. Dr. Saurabh Pandey is a MD Tropical Medicine, and he has done the fellowship in infectious diseases and from KGMU. I invite Dr. Saurabh Pandey to share his case. Dr. Saurabh Pandey?
Yeah. I'm sharing the screen.
Sir, you're not audible.
So is it visible? Yeah, is the screen visible? Dr. Akshatha, is the screen visible?
Yes, it is visible.
Okay.
Yes.
First of all, thank you very much, Dr. Akshatha, for the invitation, and I congratulate you for this organizing this CME and to have a channel on ID.
Over to you, Dr. Saurabh.
Yeah. So every long duration of fever in India isn't tuberculosis.
Sir, you're not audible. Could you unmute yourself?
Wait a minute. So is it audible now?
Sorry, sir, no issues. Please continue.
Yeah, is it audible now?
Yes, sir, you are
Yes,
audible and
yes,
your
you are
slides are
audible.
also.
Okay. So this is a case that keep tickling me even after 3 years of having diagnosed this case. This was an old man from West Bengal. So he has developed an insidious onset fever of almost a duration of 1 year. So when he visited us, he had low back pain. There was very surprisingly distinct myalgia and arthralgia, but without any active arthritis. He mentioned that he lost weight of around 5 to 6 kg in that period of time. There was intermittent anorexia, but there was no sustained anorexia in this case. All of these symptoms aggravated during the episodes of fever, which was there for at least 2 times a day, and the fever was used to stay for at least 5 times a week. So this was the presenting history. This patient was a farmer, sells his own vegetable as well as was rearing multiple cattle. So a pretty good background history of exposure. So during the last 1 year, he has received multiple injectable, multiple oral medication, including steroids, and there was minimal relief from symptom. Although the last visit he had partial response to prednisolone and naproxen, which he continued to receive for 4 weeks before he came to us. Examination, the patient was agonizing in pain. So this is something uh, very important in the background of a long duration history with multiple cattle exposure. Uh, he was febrile. What we didn't find was any inflammation anywhere in the body except tenderness of the muscles, and that minimal tenderness goes to significant tenderness when he was spiking fever. A thorough examination was done. All we found was firm hepatomegaly. There was no skin rash, lymphadenopathy, anything in the ear or in the eyes. There was no, the genitalia was also clear. So we started with a large differential diagnosis. In those days, we were diagnosis off and on chronic brucellosis. Like every month, we were diagnosing chronic brucellosis because we have increased our testing of brucellosis. So we kept 3 to 4 major differential diagnoses. The first was adult onset Still's disease, chronic brucellosis. Polymyalgia rheumatica was also kept among the DD, polymyositis, and other connective tissue disorders. So these were our top differential diagnosis. But since the fever was for almost a year and it was a type of periodic fever, we also considered it for familial Mediterranean fever. And for all the cautions, we included lymphoproliferative disorder and endemic mycosis, disseminated tuberculosis as well. So our workup was pretty exhaustive now. Investigation. Am I audible?
Yes, sir.
Yes, sir.
Yes.
If you closely look at the investigation, there are 3 striking findings. The first finding is the patient has developed neutrophilic leukocytosis. So the neutrophilia was between 80 to 85%, and from 17,000 at the start of disease, in the mid it has reached to 22,000, and then it has come down to like 12,000. Absolute eosinophil count, you see the eosinophil count was also high at the start of the disease, has gone down during the course of the disease. What has increased is ESR, what has increased is hepatomegaly, what has increased is alkaline phosphatase, as well as a minimal hepatitis with more of chronic malnutrition associated reduction in the albumin level. Keeping all this in the background, we began to investigate this patient. This patient had no good investigation in the backdrop. So ultrasound abdomen showed mild hepatomegaly and there was some hypoechoic round discrete shadows. Serum ferritin was elevated 507, serum LDH was normal. So all the basic investigations that we were doing on those days include the viral marker, uh, IgM and IgG for brucella was done. It was negative. We also did ANA, although ANA is not the best of the investigation to be done in this background. We also did ANCA, anti-CCP. Complement level were normal. And we also did serum ACE level and also serum IgG4 level, because if we go 3 year to 4 year back, there was an increase in the detection and diagnosis and reporting of IgG4 disease. An echo, 2D echo was also done, which was within the normal limit. So we asked the patient if he can afford PET CT, but on financial ground, it was put down by the patient. We managed to do CT of abdomen and thorax, and CT abdomen showed hepatomegaly with multiple decreased attenuating lesions, and similar finding was present in the spleen as well as in both the kidneys. We performed FNAC, and it was performed from two sites in liver, also was performed from pancreas. The FNAC shows minimal necrosis, and apart from necrosis, there was no other significant finding. We sent the samples for culture as well as a stain, and it all came to be negative. This was the presentation. You can see the CT, there is hepatomegaly as well as multiple small lesions. See also in the spleen as well as in the kidney. So thinking of a disseminated disease, bone marrow aspiration biopsy was performed. We sent it for culture. We sent it for mycobacterial as well as fungal as well as bacterial culture. We also sent the sample for brucellar culture, and the report was awaited. In the meantime, we also did, which I forgot to put on the slide, we did IgG Echinococcus. It was also negative. The stool examination was done for parasite. It was also negative. Meanwhile, during the stay, the patient was obviously unsatisfied because we were not able to offer him any diagnosis or any treatment. So at this point of time, after 2 weeks of stay, the patient asked us to provide him at least any therapy, which we had to offer. So since steroid had minimal effect just before coming to us, he has received high dose steroid and there was minimal effect. Our teachers told us that we should go ahead and give this patient anti-tuberculosis treatment. Although we were not in the favor of giving him treatment, but anyhow, we have to start the treatment. So for 1 week, there was no relief, and eventually the patient left us and was lost to follow up. Now, during all this time, we were thinking that what could be the possible cause of those hypoechoic lesion and 1 year of fever in the background, with so much of myalgia and so much of arpegia that the patient, it was giving patient crying, overnight crying. So there are only two important factors that comes to us, that they either represent necrosis or they represent fat. So this could be a fat necrosis within liver. So fat necrosis is very uncommon. Or if at all there is necrosis, we are not getting those necrotic, any finding from the necrotic tissue. Okay, now one very fine afternoon when I had completed my OPD, a patient came to us very smiling, and he had old investigations, and he told us, sir, why you took 2 weeks to give me a therapy? I left you and I then came back, and after 2 months, it took me 2 months, and in 2 months, sir, My life has changed from last 1.5 years. I have gained weight. My reports have improved. Now I am working again. I am not getting those arthralgia and myalgia. And this has started by the end of first month of the drug that you gave me. Finally, you gave me. So we all were completely surprised that he will have any response to the treatment that we had offered. And so then we repeated his investigation when he came to us, and we realized that his hemoglobin has improved from 10.2 to 12.2 without any supplementation. His total count, his neutrophil, absolute eosinophil count, all have gone down. ESR has gone down from 100 to 22. Hepatomegaly has regressed. Alkaline phosphatase settled. SGPT settled. Albumin improved. Our patient has improved. A repeat CT was done, and you can see there is hardly any lesion which we can see. So therefore, this case reminds us of one very important fact, that in India, even the most atypical cases can be tuberculosis because the prevalence of the disease is extremely high. Now, I would like to interact. Yeah. So I've stopped my screen sharing now. In this regard, to be extremely cautious, we repeated even the IgM IgG brucellosis again for a follow-up. That was it brucella? That was the actual diagnosis, because they will also respond to your therapy, rifampicin-based therapy. But it again came out to be negative. So this was an extra-pulmonary tuberculosis. So the carry-home message is, if at the end of the day you don't get anything, is it worth to give patient a trial of ATT, or we keep we keep our limits, we increase our limits to investigate? I welcome any question. Thank you very much.
Dr. Pandey, a very interesting case. I'm Dr. Anuradha. I just want to know why a bone marrow biopsy was not done. I think in such cases we do
Ma'am, we did a bone marrow.
decide to go for a bone marrow biopsy. It was done.
Yeah, yes, ma'am. We did bone marrow biopsy. We also did bone marrow biopsy.
Okay.
So, as the first speaker has clearly mentioned, that extrapulmonary tuberculosis is so possibacillary that sometimes you don't find that, and therefore sometimes you have to give the ATT trial that we do. But before you give the ATT trials, there is something, this is my experience or my carry-home message, that the more you try to correctly diagnose TB, the more you rule out tuberculosis. This is what my carry-home message is for everyone. Thank you.
Thank you, Dr. Saurabh Pandey. Yes, I agree. TB is one of the things. The more you stop looking for it, more you get cases of TB. And again, PO, it is already in the regimen that we have. You rule out all the possible causes, try to rule out and give a trial of ATT. Thank you again. Now I call upon Dr. Nikhil John for his presentation on the diagnosis of TB, past and the future. Over to you, Dr. Nikhil.
Good evening, everyone. Am I audible?
Yes, sir, you are audible.
So, following from Yash sir and Saurabh sir, we had two interesting cases in the management of tuberculosis. In this session, we'll be going through the various diagnostic modalities, especially the paradigm shift that we are seeing now in the diagnosis of tuberculosis. We are moving away from the conventional methods and moving towards the point of care molecular techniques. So we'll be looking at the various breakthroughs and opportunities associated with the various modalities for diagnosis of tuberculosis, and especially some of the modalities that are still in the pipeline. So according to the 2021 report, the global report of tuberculosis, estimated 10.6 million cases of tuberculosis was estimated, and only 6.4 million were diagnosed. Out of this, only 2.4 million received rapid molecular diagnosis with the status of rifampicin resistance. So, very less number of people are having access to these rapid molecular tests. So, this is an important message from this session. And out of these cases, 450,000 cases were said to be MDR TB, and of this, only 1/3 received diagnosis and treatment. So the lack of access to these tests make them difficult to diagnose and then treat these tests. With the advent of COVID, the years of struggle which have gone by in diagnosing and treating tuberculosis, we have had a setback because of COVID. But across the horizon, if we see that with the advent of COVID, we are able to incorporate certain diagnostic technologies that we used for COVID into the TB program. So those are certain things we'll be touching upon. So this is a small poem which I've added here before I enter into the session. TB has remained an elusive thief. If we see this poem, bricks and bones, sticks and stones, I chased a thief through 20 zones. I found his hat on Mount Ararat and hurried on as quick as cat. In a day or two, I found his shoe where he had sailed for Timbuktu. I met the goat that ate his coat upon the road to Terre-Haute. At last, all worn and quite forlorn, I chased him up the Matterhorn. So this poem says the person is chasing the thief and he finds small things that the person has left by, but he's not able to catch the thief. So similarly, we have put in so much effort to diagnose and treat TB as early as possible to reduce the mortality and morbidity, but still somehow we fall short in certain areas. But implementing these point of care molecular tests will be a main weapon in our armory to diagnose and treat these infections. So starting with our conventional methods, we all know that smear microscopy has been the mainstay, the initial step in diagnosis of TB. Owing to its simplicity and reproducibility, you'll be able to see the long, slender, beaded acid-fast bacilli. The downside is that it has a less sensitivity of 60%. It requires at least 5 to 10 into 10 to the power 3 bacilli per ml of sputum, the limit of detection. Cannot determine the viability of bacilli. The acid-fast characteristic of the microorganism here is attributable to the high lipid content in the bacterial cell wall. Again, a negative point is that we cannot differentiate the environmental mycobacteria, NTM from MTB based on microscopy. It is very difficult to differentiate them. So can cultures become negative before smear microscopy? Yes, it definitely can. Previously administered therapy makes the bacilli non-viable, but we continue to be eliminated by the host. So the other staining methods we have are a fluorescent staining or rhodomin staining is used when large number of samples are to be examined because the screening takes place faster. It's based on the affinity of the mycobacterial cell walls, based on the affinity of the mycobacterial cell walls, mycolic acid to these fluorescent stains. Against a dark background, we're able to see yellow or orange organisms, and this screening is usually done under 200x or 400x magnification, so it will be able to done faster. So another update here is the TB detect kit, which it's used along with the fluorescent microscopy. It has a biofilm filter, so it increases the diagnostic efficiency of sphere microscopy when LED is used in our fluorescent microscope. So next, coming to diagnosis of latent tuberculosis infections using our IGRA interferon gamma release assay and tuberculin skin test. So the update here is that now there are a lot of flow cytometric tests in the pipeline, which determine the levels of CD3, CD4, interferon alpha, TNF alpha, interferon gamma, and such markers using flow cytometry. Here in IGRA, it is only used as a supportive screening test. It is not recommended to take decisions regarding TB treatment. It detects ESAT6, CFP10, and TB 7.7. So the main thing is that the T cell mediated immunity in response to the specific mycobacterial antigens is measured here in IGRA. Blood is used as the sample. Sensitivity of this test being 75 to 80% and specificity 75 to 90%. The update in IGRA here is that a special test is there in the pipeline called heparin B hemagglutinin test. So this will help us to know the latency associated with the mycobacterial antigens, helps us to differentiate latent and active TB. So the other test being our old tuberculin skin test or Mantoux test. So we know this has a lot of disadvantages. There will be cross reactivity with BCG vaccination, NTM exposure. So moving ahead, we have a solid culture. This has always been the gold standard for diagnosis of TB. Acceptable method available for patient follow-up and to confirm cure. The results of culture are largely dependent on sample decontamination and digestion. The limit of detection that should be at least 10 to 100 bacteria per ml of sample. The downside is that it takes 4 to 6 weeks for final report to come. It is important to quantify the number of colonies in view of treatment response. Now coming to our gene expert, this is an important part in our armory for a diagnosis of tuberculosis. It's semi-quantitative nested real-time PCR in vitro test simultaneously and rapidly detects MTB complex and RIF resistance. The detection limit is 131 colony forming units per ml of sputum. It detects both live and dead bacteria. Sensitivity for AFB smear positive specimens is 99.4% and specificity is 98.7%. An AFB positive smear with a negative gene expert will usually go in line of diagnosis of non-tuberculous mycobacteria. And now there are several different cartridges coming in gene expert. We have the MTB RIF, MTB RIF Ultra, and also the MTB XDR. So the difference between the RIF Ultra mainly is that only RPO core is detected in the RIF cartridge, whereas in Ultra it has multiple targets. The limit of detection is even less in Ultra, being 11 CFU per ml. So another portable, promising, cost-effective tool is Gene Expert Omni. So it ensures point of care and is portable and reduces the cost and time involved in transporting of specimens to central laboratories. As we saw the Expert MTB cartridges, we have this XDR cartridges, which is involved in a detection of resistance to isoniazid, fluoroquinolones, ethionamide, and second-line injectables. So the main disadvantage in it is that it does not detect resistance to rifampicin. We have to use the rifampicin cartridge, either RIF or RIF Ultra, and then do these tests. So we have to do 2 tests. So this is the timeline in which these cartridges were introduced. So in addition to Cepheid being in the monopoly position in the market for almost 10 years, in 2013, WHO came up saying that we should move over to the molecular methods. Last 10 years, Cepheid has enjoyed a monopoly. Molvio has also come up with a TrueNAT kit, a simple chip-based method, but one disadvantage is that manual pipetting of samples is involved in this test, so there is result that there are chances for error and contamination. Coming over to a line probe assay, this is also an important armament, important weapon in our armament. It is based on the principle of reverse hybridization for first line drugs and second line drugs. The rapid PCR based method that amplifies DNA from Mycobacterium tuberculosis and immobilization of oligonucleotides on a strip. In the presence of gene mutations, immobilized oligonucleotides emit calorimetric signal indicating drug resistance as well as drug sensitive strains in the sample. In first line, we were able to see RPOB rifampicin resistance and high level resistance, CATG and INHA, low level resistance to isoniazid. Both we are able to see in first line, and second line we are able to see the GAIR-A, GAIR-B mutations, RRS and EIS mutations. So this is a small concept difference between hybridization and reverse hybridization. In hybridization, to the cheese, that is the DNA fragments, we dip the probe, that is the bread. Whereas in reverse hybridization, on a immobilized bread, that is the probe, we add this amplicon, that is the DNA fragments. Moving over to other liquid culture systems, we had systems like the BACTEC TB460 and the BACT-alert system. BACTEC TB460 being radiometric and not being used widely nowadays. The BACT-alert system is a non-radiometric continuous monitoring system, computerized database. It's based on the calorimetric detection of CO2. Coming to the now widely used midget tubes, the Mycobacterium growth indicator tube, fluorescent component present in the silicon at the bottom of this midget tube. This ruthenium chloride based compound present at the bottom of the tube. This fluorescent compound is sensitive to the presence of oxygen. Initially, there is large amounts of dissolved oxygen in the tube. This dissolved oxygen decreases as the Mycobacterium species grow. This results in increased fluorescence. Each midget tube is monitored every 60 minutes for increased fluorescence. So the principle is based on the growth of Mycobacterium tuberculosis isolate in drug concentration tube compared to that of a drug-free tube, where you're able to see 4 tubes, drug-containing tube and 1 growth control tube. The growth of the specimen added to the drug-containing tube is compared to the drug-free growth control, which contains the same specimen. The bacterial inoculum added to the drug-free growth control tube is 100-fold less than the inoculum added to that of the drug-containing tube. If you notice closely here you're able to see only 4 drugs out of the 5 drugs. SIRE, you're only able to see isoniazid, rifampicin, ethambutol, streptomycin. You're not able to see pyrocinamide. So the reason is that for that we have a separate tube, separate kit, owing to the low pH requirement of that drug. So here we'll get the susceptibility and the resistance report. When is it susceptible? When growth units are less than 100, the growth will be inhibited and fluorescence will be suppressed. Growth is there, fluorescence is there. If no growth is there, fluorescence won't be there. And resistant results that growth units are more than 100. That is, growth and its corresponding increase in fluorescence will be evident in both drug-containing and drug-free growth control tube. If there is resistance, you will see fluorescence in both the cells. Now, moving over to the main point of care molecular tests. Why do we need them? These point of care molecular tests, the main thing that should happen with these tests is they should be decentralized from all the central institutes, the main institutes, down to the peripheral healthcare centers, the primary healthcare centers, PHC. So an expel TB trial was done at Uganda, and they brought these point of care molecular tests, gene expert, down to the PHC level. And what they saw is a surprising increase in the diagnosis of tuberculosis, 56% increase in the diagnosis of tuberculosis cases. So such trials and such things, they have to come into our Indian setup also. So there are 2 key considerations in development of 2 molecular tests. One is to place the diagnostic instruments at primary care settings where most people attend care for TB. Second is development of newer molecular tests, especially in populations such as people with HIV, pediatric populations. It is difficult for them to produce sputum, and since they are not able to produce sputum, the sensitivity of these tests decrease drastically. So newer tests have to come for these group of patients. So decentralizing such tests will also lead to decrease in transport, will lead to reduction in the turnaround time. So these are all certain advantages that we have to look into. So the takeaway from this slide is that the hub and spoke model should be eliminated. The hub being the central institutes which have the molecular test, and the periphery only having the conventional test. This should be eliminated, and the peripheral centers should also have the point of care molecular tests. So coming to those tests which are in the pipeline, and those tests which are in clinical trials, and those tests which have been put forth by WHO. So this is our LAMP TB test, loop mediated isothermal amplification. So this is a manual assay, and results can be obtained within an hour. WHO recommends replacement of microscopy for diagnosis of pulmonary TB in adults with signs and symptoms of tuberculosis. It's especially useful in patients with smear negative cases. A single step amplification based strand displacement reaction of approximately 15 to 60 minutes at a constant temperature of 65 to 67 degrees Celsius, and the subsequent part of the test is reading the amplicon under fluorescence. So this is the LAMP test. You're able to see the positive samples having the fluorescence. Next, coming over to our CRISPR based test. The combined use of CRISPR and Cas9, that's a clustered regularly interspace repeats and are CRISPR associated nuclease 9. So these tests help to increase the sensitivity. Even single copy DNAs can be detected. It's especially useful in pediatric TB cases and smear negative paucibacillary TB cases. Decreases the turnaround time. And a study was done combining the last two tests we saw, LAMP and CRISPR, called as the TB quick study. CRISPR-Cas12b assisted rapid and sensitive detection of Mycobacterium tuberculosis. The detection is isothermal, ultra-sensitive, and rapid. The limit of detection is 1.3 copies per microliter. And another thing, there is no cross reaction with other environmental mycobacteria. So talking about our other point of care diagnostic test, this is a test which is there in the pipeline, and thanks to COVID, where we sampled all our patients using throat swabs, this is an offshoot of that, where we are using tongue swabs for the diagnosis of TB. This is called the Lumira DX system. It is in the pipeline, and it involves taking sample through tongue swabs, sample collection and lysis. Then we insert the strip and add the sample. Amplification takes only 15 minutes, and we analyze the report. The report we get in 20 minutes. Here you're able to see the chip. The chip is being inserted into the device, and the analysis is received on that device. So now there are also other additions to our tests which we got as a result of COVID. So these are bioaerosol capture concepts. So that is even using our masks to capture these bioaerosols, so that from that testing can be done. This is also in the pipeline. Coming next is our whole genome sequencing and next generation sequencing. Before we go to our targeted next generation sequencing, whole genome sequencing, we'll see a few points about that. It has 96% concordance with culture-based DST, provides comprehensive detail of the TB whole genome and genotypic susceptibility data of most drugs, especially drugs including bedaquiline and delaminin. The main use of this whole genome sequencing is that since it is not available in all centers, it is mainly used to track outbreak strain, the strain involved in a specific TB outbreak, or it is sent as a test to reference laboratories. Coming to targeted next generation sequencing, This maps specific sections of the TB genome with known mutations associated with drug resistance rather than mapping the entire genome. Whole genome sequencing, we saw the entire genome was mapped and mutations were detected. Here, only specific sections of TB genome with known mutations associated with drug resistance is detected. There's a fast turnaround time of 1 to 2 days. Liquid culture turnaround time at least 14 days. 14 days is required. Here we get it in 1 to 2 days. Another advantage is that it can be directly run on clinical samples. It does not require culture isolates. Here you are able to see the various sources that have been given to us by WHO and ICMR and FIND organization. The catalog for mutation of Mycobacterium tuberculosis complex, the use of next generation sequence for detecting drug resistance mutation. So all these are important documents. United funded sequencing and trust. Sorry. So United, Seek and Treat and World Health Organization, they have been funding FIND to make new target NGS assays with increased susceptibility, increased sensitivity for TB. So the main thing of this NGS is end-to-end solution. They start from DNA extraction, go to library preparation, target sequencing, and data analysis. So start to end takes care of everything. The main manufacturers involved here are ABL, Genoscreen, and Oxford Nanopore. So taking cues from Cepheid and Molbio, SD Biosensor and Bioneer have also come with their own products. SD Biosensor working on MDR TB assays for detection of TB and resistance to first-line drugs rifampicin and isoniazid on their standard M10 platform. This is similar to GeneXpert. Currently, they are evaluating sputum. They are also looking into other samples like tongue swabs and stool samples. Bioneer is working on a qRFIA assay, that is release fluoroimmunoassay using qPCR. So this detects resistance to first-line drugs like isoniazid, rifampicin, and second-line drugs like amikacin and fluoroquinolones like levofloxacin and moxifloxacin. So the clear advantage over expert MDR, expert MTB, XDR with this Bioneer is that there we told that we have to do ultra for rifampicin and then move over to XDR for the other drugs. But in this Bioneer, it covers all the first line drugs which is required, that is rifampicin, isoniazid, and then the other second line. Another important thing is that even though they have come up with both these assays, they do not meet the updated WHO targeted product profile, that is TPP, for the drug susceptibility testing. Because what WHO is saying is that they need tests to detect even for resistance of drugs like bedaquiline. Since bedaquiline is now starting to be incorporated into a lot of MDR TB regimens, they say that we need more assays which also include bedaquiline drug resistance detection. Coming to the next modality, is a droplet, digital droplet PCR. Sample is diluted and partitioned into several hundreds of reaction chambers. Each separate chamber contains single or more copies of target sequence, while rest do not contain target sequence. It has higher sensitivity than qPCR. It detects single copy of DNA, works on both sputum and blood. Each of these droplets are read by a dedicated droplet reader and fluorescent readers. Coming to our point of care, urine-based assays using our lipoarabdomen, detects lipoarabdomen, the mycobacterium cell wall. It is especially of great use in patients with HIV and in children owing to its non-invasive nature. In HIV patients, it has a sensitivity of 42%. It has decreased specificity, but it is especially of great importance in patients with HIV co-infection, helps in early diagnosis of TB and decreases TB related mortality by almost 15%. It is cost effective. You get a result within 20 to 25 minutes. So the first generation LAM test was from Abo, determined TB LAM and earlier TB lab. Then the second generation, they came up, Fujifilm came up with a LAM test called Silvamp TB AMP. This uses silver particles to bind to the TB antigen. It has increased sensitivity of 70% in HIV positive patients. Now WHO and find they want to come up with third generation urinary LAM test. So irrespective of the status of HIV positive or negative patient, or irrespective of the case being a pulmonary TB case or extrapulmonary TB case, they want the sensitivity of these third generation tests to be more than 65%. They're also looking into increase the urinary concentration and to use fluorescent and digital readers to increase the sensitivity of these tests. So this is a find-led drive diagnosis for TB campaign. So coming to more tests in the pipeline, there's something called Raman spectroscopy. So the phenomenon of Raman scattering is used to identify unique molecular markers of TB upon excitation of a particular wavelength of light. So we also have modality called microRNA detection. So this is like a biomarker study. So the plasma samples of pulmonary TB patients, they have expression of these microRNA, and these are used as biomarkers to detect TB. Both latent and active TB can be differentiated use of these biomarkers. So there are some other modalities also which are coming up but not widely used. NRA, nitrate reductase assay, TLA, thin layer agar culture, CRA, calorimetric redox test. There are also other new drug susceptibility tests. The MODS, microscopically observed drug susceptibility test. So due to a lack of time, we won't be going into details of the test. Now coming to a computer aided detection of digital chest X-rays. So these are artificial intelligence based algorithms where we will be able to make a diagnosis of pulmonary tuberculosis based on a given digital chest X-ray. We also have AI-enabled point-of-care ultrasounds, digital stethoscopes, and cough apps to enable the diagnosis of tuberculosis. So coming to the end of our presentation, so the take-home message is that we have come to a point where there is a possibility for us to end tuberculosis. So up till now, we have used both our conventional tests and with the use of our upcoming molecular tests, we have come to a point that we can think in the near future of ending TB. So two roads diverge in the wood, and I took the one less traveled by. That has made all the difference. So let us take the road of point of care molecular tests and decentralizing them to primary healthcare centers so that early diagnosis of TB can be done and those patients treated effectively. These are my references. Thank you.
Thank you, Dr. Nikhil, for enumerating all the various diagnostic modalities which we have currently, as well as what is expected in the future. So, TB, though the plan for ending TB is 2030 and Indian target is 2025, but the diagnosis TB is the initial thing which has to be
So for the next talk,
I invite Dr.
Rahul
Rahul
He is a senior resident in AIMS. He has done
Raipur.
PDCC
He has done PDCC infectious diseases as well as PGP epidemiology.
with over 20 publications
publication and multiple
travel grants and
travel grants
awards
and
in national
awards in national and international conferences.
So I invite Dr. Rahul Garg for his talk on emerging strategies for drug resistant testing in tuberculosis. Over to you, Dr. Rahul.
Thank you, Dr. Akshita. Can you see my slides and hear me very clearly? Hello?
Yes.
Okay, fine. So we'll start now.
Thank you, Dr. Nikhil. You made my job very easy. So today I will be talking on emerging strategies
Dr.
for
Rahul?
yeah. Please tell. Are you able to hear me?
Yes, sir. We are able to hear you and see you.
Okay, fine. So I will start with the presentation then. Uh, Everyone. So the disclosures, there is no conflict of interest to declare, and the presentation is only for the educational purpose and not a mode for any advertisement for any specific manufacturer. So everyone remember this 24th March, what has been happened. So if you remember in 2020, there was a lockdown because of the SARS-CoV-2 pandemic, which was going on globally. And after this, this was one of the pandemic, and the major pandemic is the tuberculosis, which is going on from decades, which is going on. And if you see the mortality which is there, so COVID is being the second leading cause of the MTB is the second leading cause of mortality among all the infectious diseases which is present in this globe. So I will start with this article, which is from the Karnataka and very useful article. So the implementation of the new integrated algorithms for the diagnosis of DRTB, what is there. So what they have seen, basically they have collected around 1600 samples and done the algorithm regimen to follow for the testing for both the DSTB and the DRTB. And if you will see the TRTB, there was around for risk resistant, there were around 64 samples was tested for by the expert, and that to be around half of the samples was done for the second line LPA, and the culture was done in that half also. So there was a testing seems to be the weekend link for the TB care, what is there. So coming to the resistance, first we should know what are the various modes of the resistance. So basically the MTB, because of the hydrophilic cell wall, what is there is a permittive barrier which is there for most of the antimicrobials which are present currently. And there is resistant determinants encoded in the genome also, like the presence of the hydrolytic or the drug modifying enzymes like the beta lactamases and the aminoglycoside acetyl transferases are there. And there are potential efflux pumps also there present in this MTB genome. And apart from that, there is a natural resistance to the penicillinases and the sulfonamides. And MTB bovis is naturally resistant to pyrazinamide also. So this was about the natural resistance, and there are various wild type mutants are there, which is also a natural phenomenon which is occurring in MTB. It occurs because of the chromosomal mutations that happens. And if you will see here in the table, so for various mycobacterial drugs which are there, there are various types of average mutations which is happening, and the maximum mutations happens for the rifampicin, followed by for the isoniazid that is happening. And the great thing about this MTB is that there is no plasmid mediated mutations, or there is no horizontal transfer genes are present, which are present in other bacterial genomes which are present. Coming to the acquired resistance, so as I told, there is a spontaneous mutations which happens that to be log 10 to power 8 in the isoniazid, and basically the most common reason is because of the suboptimal drug therapy which is there. Apart from that, there are various reasons for this chromosomal mutations which happens, and there is cross resistance also occurs in the TB drugs, like for Gyre A and Gyre B, there can be a cross resistance to multiple fluoroquinols. So these are the various drug mutations genes which are involved, and the role of the resistance which are there, and the level of phenotypic resistance that are there. So this is one of the important slide which depicts all the resistance genes which are there, and which we can target for the determining the DRTB also. So if we come to the clinical definition of the DRTB, there can be various type of DRTB. That can be the monoresistance to the any first line drug, or there can be polyresistant to any two or more drug except for the isoniazid and rifampicin in the first line. And there can be MDR TB, which is resistant to at least isoniazid and the rifampicin, and there can be pre-XDR involving the MDR plus the fluoroquinones, and the XDR involving the first line plus the fluoroquinones plus the group A drugs, the bedaquiline and the linezolid. So what is driving this drug-resistant TB that is there? There is the direct transmission of the already drug-resistant strain, that is the relatively transmissibility or the fitness strains that are there. And there can be resistance acquisition that can be there from the drug-sensitive TB to a MDR TB, and from a MDR TB to a drug XDR TB that can, or it can be a combination of both that can be there. So basically coming to the testing protocols, so there are two type of testing which are there. First is the drug resistant testing, which we do majority of the times by the genotypic methods, as Dr. Nikhil has told us. So these resistance tests predict the failure that is there, and that can be done from direct from the sample or from the culture itself. And there can be the drug susceptibility testing that is there. That is the phenotypic testing using the liquid culture DST, which we do for the first line and the second line drugs that are there. So the evolution of the microbiological tool happens from the smear microscopy to the molecular and now to the sequencing platforms, as Dr. Nikhil has told us very briefly. So the limitations of the gold standard phenotypic test is there, as we all know that it requires the biosafety facilities, the BSL-3 facilities per se. It is technically challenging, and there is a slow culture positivity that is there to do the phenotypic DST that has to be there. The cost, and the most important is the testing of the binary single critical concentration, which is majority of the times given by the WHO. Currently, the WHO has decreased the critical concentration of moxiflox from 1 to 0.25 that is there. And there are phenotypic DSTs for ethinomide and ethambutol, which can be inaccurate and are not reproducible. And there is no agreed DST till now for the second line drugs, including the cycloserine, imipenem, cilastatin, meropenem, and the PAS. So we all are very well aware of the algorithm that is there for the DRTB. So if you can see, for all the patient population, the first test which has to be done is the molecular test, that is the nucleic acid amplification test. And based on this nucleic amplification test, there can be two scenarios. One can be the rifampicin resistance not detected, or it can be rifampicin resistance detected. The rifampicin resistance not detected has inability go for the reflex testing of first line LPA. And in that, if first line LPA, the isoniazid came, the resistance detected, so it has the reflex testing of the second line LPA has to begin. While in the, if rifampicin resistance has been detected, so we have to go for the first line, second line, and the liquid culture DST, that all has to be done simultaneously. So WHO in his concerted guideline in 2021 has divided the molecular test based on the complexities that what are there. So that can be the low, moderate, or high complexity. The low complexity that basically depends on the how technically challenged that test is. So these are the expert platforms and the TrueNet MolBio platforms. The moderate test, as Dr. Nikhil has also showed that the About platforms, the BD, Max, MDR, TB platforms are there. And the high complexity tests are the genotype LPA that are there. So if we divide the detection of TB and the DRTB in various phases, so for detection of only the DNA, that the molecular test which can be used are the TrueNet platforms that can be there. And for detection of DNA plus RIF resistance, that can be expert platforms with RIF resistance, or the expert ultra, or the TrueNet platform itself. For the detection of DNA plus RIF resistance plus the isoniazid resistance, we have the moderate complexity test, what are there. And for detection of the first line and the second line test, we have the expert MDR, XDR platform, and the LPA test which are there. So first coming to the CBNet platforms which are there. So WHO has approved it in 2011. FDA has approved it in 2013. But in India, it takes time to come. And this is a cartridge-based nucleic acid amplification test. It is applicable for both pulmonary and extra-pulmonary TB. And the advantage is the rapid turnaround time of 3 to 4 hours that is there from the sample receiving to the report generation that is there. The major disadvantage is that it can detect only the DNA. It can't distinguish between the live and the dead bacillus. So you can't use this test as a follow-up test. So basically what has changed from 2021, just I'm enumerating that. So for the pulmonary TB, what samples or extract can be taken apart from the sputum in children? So you can take the stool or naropharyngeal or the gastric specimen can be taken. For the extrapulmonary TB, all the samples like lymph node aspirate, lymph node biopsy, pleural fluid, synovial fluid, urine can be taken as the initial diagnostic. And in the disseminated TB, for only and only for the PLHA patients, you can use blood as sample for testing that is there. So if you see, there are 5 different probes A, B, C, D, and E that are there. And the probe E is the most notorious. That is the most common mutations occur in this probe. So there is various codons which are there from 507 to 533 that are there. So the expert probes basically are the overlapping probes. You can see that coincide with the 507 to 533 probes that are there. So how the interpretation happens? First, there will be the 2 scenarios. It can be the MTB detected or MTB not detected. So for the MTB complex to be detected, it has at least 2 of the 5 probes of the molecular beacons has to be positive. And according to that, and with the help of the CT values, it gives a high detected, medium detected, low detected, or very low detected. And then once it is detected, then it go for the rifampicin resistance detection. That is basically it inhibits the hybridization of the overlapping probes that encompass the 81 base pair RR-DRP region that is there. So again, there can be 2 scenarios that can be there. If any probe having a negative value, that is the CT value is 0, or the difference between the max and minimum is more than 3.5, then it will be the RIF resistance is detected. And if all the 5 probes are positive, but the CT max is less than equal to 3.5, then it will be RIF resistance not detected. So I will show you this example for your better understanding. So here you can see there is various 5 probes, then the SPC, and there are 2 quality checks are there. If you see the CT values of these 5 probes A, B, C, D, and E, so you can see the maximum value that is there is the 37.3, the CT value for the probe E, and the minimum value is the 32 that is there. So if we see, so there the delta CT max difference is around 5.3, which is more than 3.5. So it will be first the CT value is more than 28 that is there, so it is very low, and then the MTB is detected because the delta CT difference is more than 3.5. So this is the various sensitivity and specificity of the test for MTB detection and the rifampicin resistance detection. It varies from 72 to 99% for the sensitivity, and the specificity is around 99% that is there for the MTB. Now the expert platform, what you see, you get the result, it has MTB detected or MTB not detected. But the question arises whether it detected only the MTB or it detected the MTB complex. As we all know, there are various species of the MTB complex which are involved in causing the tuberculosis. So basically, the species in the MTB complex has the same RPO core regions that has been sequenced. So the expert only detect the MTB complex. It doesn't detect only the MTB. So the correct term to be used every time when you are giving the report, it should be MTB complex detected and not the MTB detected. So there can be various diagnostic discordance which can be there, which I think you every day you see by your lab or whenever you are in the clinics. So sometimes the molecular test will be rifampicin will be detected resistant, and the major platforms, the DST, you will see the RIF is sensitive. So it can be because of the synonymous mutations or the low confidence mutations, or because of the silent mutation. In the subsequent slide, I will tell you about this. And many times it can be the expert MTB load, you will see detected very low with the RIF resistance, but you will check again, so it will come at RIF sensitive. So again, the scenario can be vice versa. The expert has giving RIF sensitive, but the midget DST is giving RIF resistant. So it can be because of the mutations that are outside the hotspots which are there. So expert is only detecting from the 507 to 533, but there can be mutations outside these hotspots also, or it can be because of the heteroresistance. So here, if you can see, the probe E was where the most common mutations happen, but the probe E is where most common the silent mutations happens. though MTB detect is at RIF resistance, but these silent mutations are not generally the of the resistance purpose. So many times you people see a report as a very low load detected. So many times it comes as the discordant result with the phenotypic DST. So because it gives us a false positive result because of the inadequate efficacy of the expert probe binding. And basically it happens when the patients are of pediatric population or the extrapulmonary samples or they are HIV co-infected pulmonary TB. So this is a very nice study which is published in International Journal of Tuberculosis and Lung Diseases. The impact of bacillary load on the accuracy of rifampicin resistance by the expert MTB RIF. So they have done it in the 7 different countries. And if you see in the India, the very low load was detected in around 3% of the samples which was tested. And the reason the comment was given that for the MTB detected very low, the resistance should either be inferred and the repeat sample should be asked for, or there should be a pre-test prevalence. You should know that the prevalence in that region is more than around 10%, so that you can give it as a rifampicin resistance without retesting. Now about the silent mutations which happens because of the modifier of the nucleotide, but it doesn't change the amino acids. So that's why it is known as the silent mutations. But the expert MTB RIF detects it as a RIF resistance. This is a major drawback with the expert MTB RIF, which is correctly done by the Ultra, where it doesn't do like this. So coming to the TrueNet platforms, it is our indigenous platform, the chip-based platform. What is there already? Dr. Nikhil has told broadly about this. So there is different sequential steps which are involved. First, you have to stack the DNA. Then there will be MTB detection will be there, and if MTB detection is there, then only rifampicin resistance detection will be done. So there are various platforms which are there for the TrueNet chips also. There are MTB, MTB plus, and MTB RIF DX. So the DX, there will be detection of the RPO gene again, along with the RIF resistance gene that will be there. So this is the various performance accuracy of the MTB RIF for the pulmonary samples that are there. So again, it gives overall sensitivity around 84 to 88% and the specificity around 98 to 99% in both the smear positive and the smear negative patient. Now coming to the expert ultra RIF, expert ultra. So basically important is to know how it is different from expert MTB RIF. So it uses the platform of multi-curve analysis. So what happens whenever there is dsDNA probe binding will be there along with the TB DNA. So if there is a probe which has detected any mutations along with the TB DNA, it will dissociate sooner than the normal probe. So you can see in this diagram also, the mutant have dissociated and showing the multi-curve before in comparison to the normal MTB. So what is the difference basically between the expert and the MTB RIF? So both detect the MTB complex and the RIF resistance, but the detection targets are different. So here only the RPO-B gene is seen, but here the RPO gene along with two different copies of IS6610 and IS1081 probes are being used. Both are using the semi-nested PCR, but along with this, the Ultra is using the melt curve analysis too, because of which the limit of detection is low. Again, thus PCR sample requires more in expert Ultra in comparison to the MTB RIF. So that's why the sensitivity of expert Ultra is more, but the specificity goes down in comparison to expert MTB RIF. So if you can see the interpretation of expert Ultra, how to do that. So first and foremost thing is to check the probe. If the probe check is accurate, passed, then you have to see the multi-copy target that is there. You have to see, and along with the RPO probes are there. So if they are multi-copy targets are there along with the RPO probes, at least less than 2 probes are being binded, so it will give a too low concentration MTB trace detected. And if at least 2 or more than 2 probes of the RPO gene is binded, then it will show RPO detected, MTB detected, and it can be vary according to the CT value and the multiple analysis that is there. So what is the difference between MTB RIF and MTB Extra Ultra is the possibility of we can detect either not detected, high, low, medium, and the trace is also detected with the MTB ultra. Along with that, the MTB is only detected if there is multi-copy target is there and at least 2 RPO-B probes are positive. So coming to expert XTR, which is now an upcoming in many centers sooner or later. So it takes less than 90 minutes time, and it can detect along with the first line few drugs except the rifampicin. It can detect the second line drugs too, like the fluoroquinolones. Now the second line injectables are out of the management system, so that's why in the second line it is only the fluoroquinolones that is there. So it uses the 10 color modules. The normal MTB RIF, there is a 6 color module which is there in most of the lab, I think, but it requires an extra platform that is the MTB color that is there. So what are the different gene targets that is there? You can see for isoniazid, they have taken various gene targets, the INHA promoter, CATG, FAB, OxyR, that is there for ethionamide, that is there fluoroquinolones, both gyrase A, gyrase B are there, and that are there. And it takes less than 90 minutes for there. And the limit of detection is for the raw sputum, it is 136 CFU per ml, and for the sediments, it is 86 CFU per ml. So the sensitivity and the specificity for both the phenotypic and the sequence by the sequencing method has been seen, and it gives around the sensitivity of 90 to 94%, while the specificity of 99% for various first line and second line drugs. Only for the capreomycin, the sensitivity goes down along with that. Otherwise, for all with ethionamide or for all other, it is fine. So what is the diagnostic pathway? If you use the ultra first and you get the MTB detected with RIF sensitive, then you can go for the isoniazid testing by the XDR, or you can, if there is MTB RIF resistance detected, then again you can go for the XDR, and it will take 90 minutes here and 80 minutes here to give you the result and optimize the management. So coming to the LPA, Dr. Nikhil has already told about the LPA, the first line and the second line LPA are there. So what is the workflow? First, we have to do the DNA extraction in a BSL-3, then the amplification and the reverse hybridization, followed by the interpretation that has to be done. So there are various strips. I'm well aware that you all people have seen these LPA strips for the first line, the second line drugs. So there is a conjugate control, amplification control, and the TUB bands which are there. So whenever you are interpreting these LPA assays, first you have to see the controls have passed or not. So basically, these are the testing controls which are there, the conjugate controls which tell about the working of the conjugate or the substrate. The amplification control will tell about how accurately you have done the amplification. And there will be a TUB complex which will tell about the MTB complex is present or not present. Then there are different locus controls, like RPO-B locus control is there, CATG locus control is there, and INHA control locus is there. So you have to see these local controls have came or not. And then there are various wild types that are there in which there is no mutations, and there is various mutations that are there for rifampicin and the isoniazid in the first line that are there. So if you see this LPA strip, there are various case scenarios which are there. So in the first, you will see first the controls are working, all the locus bands are fine, and then you will see the wild bands are present or absent. So if all the wild bands are present in for the RPO, CATG, and INHA, so it is a you will tell that rifampicin the resistance was not detected and the INH resistance was not detected. If there is an absence of one of the wild type, and to that there is a presence of a mutant that is there, then you will tell that the RPO, the rifampicin resistance is detected, or the CATG resistance has been detected, as the case tells. But if there is, suppose there is a situation where there is no wild type present and there is no appearance of any mutations in the mute gene, or so that will be called as the resistance is inferred, that is there. So this is for the second line where we test the fluoroquinolones and the second line injectables. Second line injectables are now out of the treatment. So the clinical interpretation, how it has to be gone, you have to first see whether it's a high level or low level, what type of resistance is there, which gene is involved in that, which mutations has came like mut3 on the RPO or the mut1 or the mut2, whether the resistance is detected or inferred, and if there is high level resistance, then that drug cannot be effective with the increased dose also. So this is just a clinical interpretation example how to go about. Like in the isoniazid, you can see the CAT-G if it is present. So it tells that whenever CAT-G is present, it tells that there is a high level resistance to isoniazid, and you can't use isoniazid even in the higher doses. But if there is only INHA mutation has been detected, then that tells us that there is a low level isoniazid resistance is there, and you can use the isoniazid in a high doses that can be there. Same for the fluoroquinolones. But apart from these all molecular tests which we have and which we are using in our labs, there is a huge diagnostic gap because of the phenotypic testing that lacks the accuracy and the reproducibility. Again, the setup which we require, the genetic test which is having the limited mutations, the mixed infections or the heteroresistance that is there, and there is 5 to 10% there is a missed cases of the rifampicin or the isoniazid resistance. So that's why there is a need to come with the sequencing platforms to channelize your therapy or to personalize your management for the patient. So if we compare all these modalities which is there, the smear, the expert, phenotypic, and the whole genome sequencing that are there. So as we go about, the limit of detection goes down. You can detect as less as sample you can do. And all other promising platforms which are there, or the future upcoming platforms, or the genome sequencing that are there. But the genome sequencing is, yes, it is potentially one of the costlier platform comparable to other platforms which are there now. So WHO has given in 2018 the technical guidance for the use of next generation sequencing. But the question arises, what are the technology platform available? And does our national guideline will accommodate these technical platforms in the institutes, tertiary care institutes or not? So there are different DNA sequencing platforms, that are the Sanger sequencing, pyrosequencing, and the next generation sequencing. So basically for TB, most commonly the pyrosequencing or the next gen sequencing has been used. Pyrosequencing, the advantage is that it can be used for both the direct and the indirect samples from directly from either the sample or from the growth that can be there, and there can be a species identification with the detection of the drug resistance, that to be low and medium depending on the mutations which are present in the genes, and that the genotyping can be done. Apart from that, the targeted and the whole genome sequencing is there. One of the disadvantages of the whole genome sequencing is that it can currently be done in the indirect samples that are there, and again a large variety of genes can be detected by this. So coming to the pyrosequencing, it is a semi-automated sequencer platform which quantitatively declares the release of pyrophosphates from the DNA synthesis that are there, and it only detects the known mutations which are there in the library, that is only detected by the pyrosequencing. But the next generation sequencing can detect a lot of genes, mutated genes that can be there. So for that, there is a various catalog which is given by the WHO and the National Tuberculosis Control Program also, elimination program also. So the applications are for the diagnosis of drug-resistant TB, for the transmissions analysis as a epidemiological purpose, or for the new MTB drug detections that is there. So what is the difference? Basically, as the name suggests, for the target NGS, we know what target has to be detected, or what we have to see in the different targets which are there for different drug resistance which is there. And in the whole genome sequencing, you can sequence the whole genome that is there. So that's why it is more technically challenged in comparison to the targeted sequencing. So these are the common genomes which are detected by the targeted sequences or the whole genome sequences. So how the workflow goes for the target sequences, you have to first collect the first sample from the patients, go for the DNA isolation, and then you have to prepare the library, go for the next generation sequencing, and then you have to do reporting as per the various genomes which are given in the by the WHO catalog. While in the WGS, you have to collect the sample or you have to culture it, and then after the culture came, you have to go for the whole genome sequencing. So basically for the whole genome sequencing, the catalog has given the Illumina platform as the more promising platform in comparison to the nanopore or the iron torrent that is there. So the target sequencing is basically nowadays done for 15 anti-tubercular drugs, apart from the Nilios and the Sporotangi that is done. And it can detect the heteroresistance and the mixed infections also that has to be done. So this is the WHO catalog, which was released in 2021 for more than 40,000 TB strains, including various type of genes which are involved in the drug resistance that are there. And this is the 2022 Indian catalog, which is there from various parts, various states of India. They have taken the sample, they have done the whole the sequencing, the targeted and the whole genome sequencing, and they have made a library of various genes which are involved in the Indian isolates that are there. So outlook of the DRTB, the depth sequencing, once you go from the WHGS guideline, you have to go for the NGS platform, detect what variants are there, see what these mutations are for resistance or the susceptible matching with the WHO catalog, and go for the treatment algorithm. So currently, these target sequencing are placed in various Indian tertiary care centers for evaluation by the find. The most commonly used is the duplex MYC TB assay, which can detect all these genes which are involved in the drug mutations that are there. So it can predict around 15 anti-tubercular drugs that is there, and it can amplify and sequence the 22 microbacterial loci, including the 20 known which are involved in the MPTB and TB resistance for the first line and the second line. So as I told, it is the advantage is for the DRTB surgery testing or for the surveillance purpose or the epidemiological purpose. The challenges are basically first is the cost that is there, the bioinformatics which is required, the setup which is required, and again the quality control which has to be taken into consideration. So this slide I was taken from the Muthar, which I recently published in the SIST webinar. These are the promising platforms which are upcoming from 2023 onwards. There are various target sequencers or the MDX platform, the moderate complex platforms which are there, and again the third generation LAM which is coming up. Apart from this, there is a current knowledge gaps which are there. First, on the molecular basis of resistance, which is there basically for the group A and the group B drugs for the XDR. And there is a basically discordance between the phenotypic and the genotypic DSTs, how to understand that. I hope I have made some help for you regarding the understanding. And apart from that, how to go about the contribution of the heteroresistance or the various efflux pump and the compensatory mechanisms. Thank you.
Thank you, Dr. Rahul, for such an extensive discussion on drug resistance testing in TB. I'm sure everyone will agree. If there are any questions, we can take it at the end. So we'll move on to the next talk. For this, I invite Dr. Ramya S. Dr. Ramya S. Is a DNB Family Medicine, and she has completed fellowship in infectious diseases from Deennath Mangeshkar Hospital. She has various publications and as well as a YouTube channel, and is a state secretary of Spice Route Maharashtra chapter. So I invite Dr. Ramya for the discussion, case-based discussion of the difficult to manage cases of TB. Over to you, Dr. Ramya.
Good evening, Dr. Akshatha. Thank you so much for the opportunity.
Dr. Ramya, could you please share your slides?
Can you see my slides?
Dr. Ramya?
Dr. Akshatha, is visible?
No, they are not visible.
Not visible. Okay. How about now?
Not yet, ma'am.
There are slight technical glitches on Dr. Ramya's side. So I request Dr. Santana. Okay, she's there. Yeah.
Can
Over
you
to
see?
Dr. Ramya?
Yes, is it visible?
Not yet, ma'am. It's
Okay.
still showing
Good
as
evening.
loading.
Thank you. Loading.
Yes, ma'am. Now it's visible.
Yeah.
Your slides are visible.
Good evening. Thank you so much, Dr. Akshatha.
Could you unmute yourself?
Yes, thank you.
And put it on a slideshow now.
Yeah, I have done that. See now?
Yes, it is in the slideshow. You can proceed, Dr. Ramya.
Thank you. Thank you so much, Akshata, for this wonderful opportunity to be presenting a case tonight. So this about a 34-year-old girl who presented to us with fever for 2 weeks and weight loss for 4 weeks. She was empirically started on ATT by first line ATT by a local physician in December 2019. She bought us few reports with the normal CBC, chest X-ray normal, raised ESR, strong positive TTT and TB gold assay. Based on all these reports, she was started on ATT by a local physician. And she also told that after starting on ATT, her fever was coming down. Examination, her weight was 61 kgs. She was mild febrile, multiple supraclavicular lymph nodes were present. Her temperature was 99 with tachycardia, mild splenomegaly was there, and also right axillary lymph node about 2x2 present, which we drained it. And yes, after draining, this was the culture report. You can see that in the first line, isoniazid and pyrazinamide were resistant. After, we generally don't do sensitivity in our hospital for all the drugs at once. We do for first line, and only if we find something resistant, we request for sensitivity for second line. So when that was done, we get the second line sensitivity. So based on this report, we started with her with rifampicin, ethambutol, moxiflox. Since a proven sensitivity for lymphadenopathy, we started her with 3 drugs and with Benadryl. This was going well until when she, in April 2020, she presented with right supraclavicular and right axillary lymph nodes. Initially, we thought probably could it be reactive, but since it was multiple presentations, we drained it. Same thing happened in June and August. Some were drained, some were not drained. And from whatever was drained, we did not get any growth from any of the cultures. So we thought she's responding from treatment. It is just a reactionary swelling. November 2020, she finishes her treatment. There is resolution of fever. There is resolution of lymphadenopathy. There is weight gain. So we close the case saying, declaring her cured. However, next within 2 months, she again presents with fever of 2 weeks, same, right supraclavicular lymph node. We drained that, and now it was started her with similar regimen, except that we added even Hanseparan this time. And we sent the culture sensitivity from the lymph node. This, surprisingly, you can see that isoniazid and pyrazinamide has become sensitive. So we thought, okay, she has come up with a new infection. And we started her with, again, first line. We changed her to first line. Now, what was resistant earlier has come as sensitive now. So we were thinking, could it be a case of heteroresistance? Could it be a thing with 2 species? So we let her continue with first line. Then in August 2021, she presented with breathing difficulty, some pleuritic chest pain. Chest X-ray was some minimal amount of pleural effusion. Now we had got this culture report, which you had seen here. So instead of draining that small amount of pleural effusion, which was probably not drainable, whatever culture sensitivity we had got here, as Dr. Rahul had explained in detail about sequencing, So that from the culture report, we sent it for whole genome sequencing. From whole genome sequencing, this is the whole genome pattern. I'll go in detail with the report. You can see that it has detected RPOB, that is resistant to rifampicin, presence of CATG resistant to isoniazid, RV3169 for pyrazinamide, and ethambutol MB resistance has been detected. Second line, there is no resistance detected. So based on this regimen, now it was concluded, based on this report, it was concluded that she was resistant to all first line drugs. She was sensitive to second line drugs, and she was started with moxiflox, ansepran, ethambutol, and bedaquiline. Bedaquiline, she finishes 24 weeks, and after that she starts over with the continuation phase. And finally, she completes 18 months of therapy. And now she's febrile. She has had her weight gain. She has never got her lymph node swelling bags, and she's clinically doing well. Why I took up this case is I thought I'll pinpoint and discuss two challenges in the management of tuberculosis. One is heteroresistance. So what is this heteroresistance? Whenever there is mixed population of isolates, when you start an antibiotic, there will be selection of resistant isolates. So long this the present antibiotic. There is one more point we need to know, that so long there is antibiotic, there can be maintenance of this resistant isolates, and whenever without antibiotic, there can be loss of this resistant isolation. So why do we do this? Traditionally, it was known that every 10 raised to 8 harbors one isoniazid species, and every 10 raised to 6 harbors one rifampicin resistant species. So overall, over 10, every 10 raised to 14 can be an MDR. This is the rationale of starting multiple drug or at least 3 to 4 drug therapy we know. So if, when you find or when you come across such a case, what should you do? You can go for various molecular tests, and as Dr. Rahul has discussed in detail, one of the diagnostic options will be sequencing. So what do you do in sequencing? You have two approaches. One is targeted new generation sequencing. New AGS approach, one advantage is it's application-based sequencing. You can whole genome approach requires a culture. Based on this culture, and you parallel with the phenotypic DSC, you get result. And this whole sequencing can also be used for epidemiological investigations. What is the advantage of sequencing? Main thing is detection of Miru VNTR. What is Miru VNTR? Mycobacteria interspecies repetitive variable random repeat. That means when there's more than one type of population, your approach or whole genome sequencing approach or any sequencing can detect that population and give you the sensitivity pattern, and this can help in therapy.
Dr. Ramya. I think we have lost it. I'll just try to contact. There was a network glitch with her. Okay, we have her back. Dr. Ramya, please continue. Unmute yourself. Dr. Ramya, you're not audible. You're muted.
Can you hear me now? Can you hear me now?
Yeah, you are audible.
Yes, ma'am.
Okay, thanks. So next challenge is, what is therapeutic drug monitoring and do you do regularly to all patients? Ideally, I would like to say yes, but it can be a painful process. So at least reserve it to those who are showing slow and lack of response. If you suspect a clinical worsening or a complicated disease like pulmonary disease, cavitary disease, if there is a relapse, if there is known drug interactions, especially
Dr. Ramya, you're not audible. Your voice is breaking. Are you with us?
status and you have increased and drug resistant TB for the similar reason I told. Next, when do you do a therapeutic drug monitoring? Ideally, it is 2 hours peak the drug consumption. That is called as C2 max, mainly because these troughs are often slightly below the detection limit. It also gives you the absorption minutes, and T max for most of the drugs is approximately near 2 hours. So that is why you use 2 hours as a standard. You can also use a 2 and 6 hours. That will also give you detection as to absorption information as well. Having said that, is 2 hours, is it a standard thing? Is it always 2 hours for each and every case? No. So finally, look for the indication for TDM, whether it is related to taking only the peak level. For such cases, when you do a 2 to 3, it is more than enough. If you're suspecting for more than something like absorption related disorders or diabetes or GI related disorders is there, then along with the 2 to 3 hours, also add one more at the 6 hours. So you do a blood draw at 2 hours post drug consumption and then 6 hours after drug consumption. Next, when there is severe meningitis or when there is severe TB like cavitary or immunocompromised meningitis, that time you can vary between 138, or this is just a random example, or you can do an AUC for 0 to 24 based on how severity the case is. Since there is no established guidelines as to what is the exact level of doing a TDM for the TB drugs, it is up to you to decide what kind of TDM you want to opt for. Are you opting for looking for only adherence and suspected drug levels or side effects? You can opt for this. If you're looking for any GI related disorders and checking for the absorption part, you add a 6R1. If there is looking for severe TB or meningitis, or do you want a very strict drug level of AUC 0 to 24, you can opt for that as well. So this is from a Netherlands journal who had followed this, and they have come up with a concentration as whenever there is any undetectable levels, you should question whether the drug was taken or problem with the absorption. When drug has been taken and levels are between 3 to 5, that is when you consider that it is adequate. If it is not, then you have to reevaluate and find and make sure you titrate the dose. How much can you titrate the dose? I'll, due to short of time, I am discussing only about rifampicin. Rifampicin has been administered at 600, 900, 1200. I know, shocking for me as well. But 1200 has definitely helped you achieve higher peaks. But did it convert into a clinical outcome? Sadly, no. They did not improve in bacterial response in patients with, especially pulmonary TB. Then why are we discussing all these TDMs and why am I wasting your time? Mainly because if at least the drug level is low, you need to find that. And you need to hike the dose and make sure you attain the adequate drug level. Only then it will translate into a good clinical response. So bottom line is to give the give subjective for the patient specific information, and it is just this information can give you enhanced options regarding dose and medications to treat the medications. So how does the flow chart look like? When you start a treatment, do a TDM, and especially consider in those, especially if they're having HIV, type 2, any GI tract diseases, or if there is any adverse events, or if they are failing treatment. Okay, after you do a TDM, you do a dose adjustment. What most of us don't follow is you do a TDM. If the level is low, you hike the dose and you forget it. This should be avoided as much as possible, is just a request. When you adjust the dose as per the MIC, please repeat the TDM and make sure the levels are okay, because I am recommending you TDM only in these kind of population and not in each and every TB patient you treat, especially in a high load country like India. So when you do a drug adjustment, when you hike a dose, repeat the TDM and follow them after 1 to 2 weeks. With this, end TB with precision treatment, taken from European Respiratory Journal. So thank you, Akshata. Thank you so much for this opportunity. I'm really apologize for my connectivity issues.
Thank you, Dr. Ramya, for bringing forward the various difficulties, especially the TDM and the requirement of sequencing and what it does in the management. So this truly brings into highlight that the empiric TB treatments which we carry out may be more harmful to the patient than useful. So that was one part of the difficult to manage case, that is when we are having drug resistant and when the levels are not achieved. So the other part of the difficult to treat TB case is the various adverse reactions which we encounter with these various TB drugs. So for this, I call upon Dr. Santanam. He is a final year ID resident in AIIMS Jodhpur. He has various publications as well as presented in various international conferences and a winner of various SIDS quiz. So over to you, Dr. Santanam.
Good evening, ma'am. I'm audible, I hope. Starting with difficult to treat TB case, what we got last 3 months back. Okay. 40-year-old male from Rajasthan, he is smoker alcoholic. He came to casualty emergency that time. Patient had a history of fever for 30 days in the form of continuous high-grade fever, purulent cough for 20 days, headache for 10 days, and altered sensory for 5 days. This much history patient attended given that time. We went for examination. Patient at presentation unconscious, dyspnea, general examination shows clubbing, and vital shows respiratory rate high and febrile. Room made SpO2 91%. We went for central nervous system examination at this time. Patient GCS have 9/50 and meningeal signs positive and plantars are muted. In view of low GCS, patient is intubated and started antibiotic with ceftriaxone and vancomycin. At presentation, we have different diagnosis. We have whether bacterial, viral, fungal, TB, but viral chronic less common. Then basic investigation shows elevated inflammatory marker like ESR, CRP, and ProCal, but total count is normal. We went for a LFT also. The albumin is low, 2.1 around the range. Then we went for X-ray. X-ray shows mild basal infiltration. CT prime, we went at that time leptomeningeal enhancement. What is leptomeningeal enhancement? It means pyo and arachnoid matter involvement with mild basal enhancement. We had our patient. We went for CSF after ruling out CT any mass or anything. Protein is high and sugar is low. Fluoride is 112 in the form of lower side. ADA is 5. Mildly lower side, whether we have TB or not. Then we went for retrostatus. Retrostatus came positive and CD4 count is very low, 43 cells. At present, we have different diagnosis. HIV we went to bacterial, syphilis, TB, even fungal possible, histoplasma, aspergillosis possible, even CME possible, toxoplasma also possible, even strangulitis, rarely positive will get it. Whether we test for TB possibility because the protein is high, sugar is low, less than 2/3 the range. ADA is 5, even leptomeningeal enhancement, basal infill, mild basal enhancement also we have got it. We went for that. We active intervention, active interdisciplinary purpose, we put it for this course. Which of the following is not used in TB, but time purpose I am skipping. Marais criteria, Landscape score, Savoy score, and CMC Wellows score, and TBM score. If you go, all are used for mainly for TB meningitis, whether ruling out from bacterial, but CMC Wellows score mainly for ATT-induced hepatitis we are using. This is the white score, whether bacterial or TB we are using for that one. This one score, our patient age is 42, score is in the form 2. The duration of illness more than 6 days, -5. We got it -3 score. It will be score less than 4, favor for TB meningitis. The white TBM score, another score is we went for Landscape score score. We got it. Our patient had, they have different score, different formats, clinical, radiological, CSF. Clinically, our patient have more than, we got a 6 in the form of symptoms more than 5 days, symptoms at least that one score also, alto-sensorium also we got it. 6. CSF criteria shows 4, clear and cells are around the left, cells also fitting, lymphocyte predominant, even that glucose ratio also fitting, 4. CT brain we got it, basal enhancement, 2 only we got it. And evidence of TB elsewhere we checked that the lungs may only mild infiltrate, but we went for Ryle strip aspiration, even tracheal aspiration, even CSF ZL stain, we got it positive. Even 3+ we got it from tracheal aspiration, even CSF ZL is come positive. This is in the form of some immunodeficiency patients, we get it very high level of even in CSF, even Ryle strip also we get it. 10 to 30% patients, usually we get it, even meningitis patients, we get it, Ryle strip aspiration give positive. The maximum patient is in the form of disseminated form. Ryle strip is mainly important for childhood. They are unable to cough expectorate. That's why we are using the, here adult also some role for Ryle strip. Our patient got it, Landscape score is 16 and the white score is -3. Then we started in the form of score is CD4 40 only. Then we started with ATT, ART, and even dexamethasone, even cotrimoxazole prophylaxis also we started. On the day 5, patients developed ATT-induced hepatitis, OTPT high, even bilirubin also high. Then we stopped all ATT, even cotrimoxazole, but ART we continued. Then modified ATT we started, and then we reintroduced in the order of HRZ. Then slowly we started with low dose and increase, and patient started even cotrimoxazole also we added, and patient improved well. I'm going to tell what is the form of ATT-induced hepatitis. Without symptoms more than 5 times, with symptoms more than 3 times, consider as ATT-induced hepatitis. But the patient previously normal LFT, but after withdrawing of ATT, patient need to improve. There's so much mismanagement between CLD. This one CMC Wellows score. This one used for mainly ATT-induced hepatitis. This one study previously published. But what's the drawback? Previously, they 2017 or 18 they used for weekly thrice regimen. Now everything came up daily regimen. This one scheduled for routinely we are using. Sensitivity specificity reasonably good. This, suppose we are going for all hepatotoxicity, we are mainly worrying about ATT. It's even first line, second line, we are worrying. First line, isoniazid, rifampicin, pyrosinamide. Pyrosinamide is most hepatotoxic, whether dose dependent or dose independent, both mechanisms are possible. Second line, ethionamide, paramino certificate, TAS, even bedaquiline also will possible. ARV, nevirapine, efavirenz, and protease inhibitor commonly will cause. Even cotrimoxazole, also mainly we are treating candida, common in our HIV plus TB patients. Isoniazid, idiosyncratic is main mechanism. Rifampicin, only thing we need to worry about mainly hyperbilirubinemia, isolated hyperbilirubinemia, we think about rifampicin. Pyrosinamide is most hepatotoxic drug. There is multiple mechanism is there. I'm not going in details. This is guideline, different guideline, ATS, American Thoracic Society, British Thoracic Society, European Thoracic Society. The question is when to stop, when to restart, what drug, the order. That is different guidelines, different things they're telling. Usually we'll stop for if more than 5 times, even without symptoms, we need to stop. When to restart? A normal limit usually we'll wait for that. Otherwise, even 80 will start. But order is not significant. Whatever you want to start, whether isoniazid or rifampicin. Why I'm telling, I will tell later. Even every 2 days or 3 days, possibly you check for LFT. One by one you add it. If again he developed ATT-induced hepatitis, whichever is last drug will cause ATT-induced hepatitis, better avoid it. This is mild, different grading, mild, moderate, severe. Mild, they have only less than 200 OTPT. Better you continue asymptomatic patient. If moderate, they have 2 types, whether express or non-clinically well patients. Express means only hyperbilirubinemia, isolated hyperbilirubinemia, rifampicin. Cotrimoxazole also possible in our patient. Cotrimoxazole, but alkaline phosphate is predominantly elevated. Moderate means they have OTPT more than 200 plus irrespective of bilirubin, whether low or high. That is another type in moderate. That ones I will tell later. Severe also is more than 200. Patient has severe abdominal pain. What that I will tell. See, moderate and severe, very high risk patient will stop for ATT first. If cotrimoxazole, whether the alkaline phosphatase we need to check for that. Based on that, we need to stop. If start for modified regimen, there is no clear-cut guideline. Whether we'll wait, if patient improving, wait for 1 week. If not improving, better restart with modified regimen. Already patient on ART more than 6 months, better consider, don't need to stop. If patient newly started, whether you check for which drug. Even after stopping ATT, after 7 days, you will stop for ART. Patient suppose not improving. Every 3rd day or 2nd day, you check for LFT. Once improve, then restart it with low dose and titrate at the level of. Telling isoniazid rifampicin, whichever you want to start it. Why I'm telling? There is IDSA guideline, they publish that 3-arm study, they publish that. Whether one patient started with HRZ in order, one patient first rifampicin, one patient in the form of isoniazid and low dose, high dose, the order of they started, whatever it. But conclusion is, there is no difference. This study have so much, p-value also not significant, but reasonably good. Some PLD patients, how many ATT given ATT drug will give first line ATT, that one is also worry. Every time we will get it one case we are getting, then only we'll get a doubt. Whether child could score based on that, better we'll go for that. A means A, B, C, we need to go for that. A means will be for 2 drugs. 1 means B means will give for 1 drug. C means another drug. The only problem we need to give for extended duration in CLD. Based on that ABC score. Coming back to our case, the patient modified ATT, again they improved. Again, after comes few times, he came for follow-up, he developed severe itching in all over the body. Then we stopped ATT and cotrimoxazole again. We restarted with the order of isoniazid. Last in reformation we started. The culprit drug is reformation, and then we changed the drug to levofloxacin, and we planned for extension also. Extended duration also we are planning. The most common drug identified for sensitivity, if we go, reformation will be most common drug. The main problem is in reformation in CNS. Suppose you are checking for 10 to 30% only CNS penetration will be there. Even reformation, even ethamphetamine. The most potent drug is in CNS penetration is pyrazinamide. The second most is isoniazid. CNS penetration will be good drug, reasonably good drug. Even again rechallenging, the many studies different guidelines they giving. As per my opinion, better you start with reformation. Lastly, better you start. The maximum toxicity is with reformation. With my speech, I will conclude that. Thank you so much.
Thank you, Dr. Santanam, for enumerating the various adverse effects following the initiation of ATT and discussing in detail the management of adverse reaction to ATT. So if anyone is having any questions, can put in the chat box. And also, this brings us to the almost the end of the CME. So I have a TB quiz. So exciting prizes are there for the winners. So kindly stay tuned.
Moving on to the next session, I invite Dr. Akshatha ma'am. She's a final year senior resident from AIIMS Jodhpur. She's doing her DM in infectious diseases. She has more than 20 publications in national and international journals and contributed 10 book chapters in the essentials of antimicrobial stewardship. She has won several prizes in national level quiz competitions, ASPICON and SITSCON. I call ma'am now for her presentation regarding the management of tuberculosis.
Thank you, Dr. Nitin. So I hope people are still awake. I am ready to, I will try to keep my talk as short as possible. Is my slide visible and I am audible? Okay. So this brings us to the last part of this TB CME. So yes, we can end the TB. That is the theme of this year's World TB Day. So I'll be discussing from past to the future, the evolution of TB treatment strategy. So first and foremost, who is he? So I'm sure all of you would recognize this is no one but none other than Robert Koch, and he discovered the TB bacilli, and it was announced on March 24, 1882, and that's the reason we are celebrating World Tuberculosis Day on this day, and for which he had got Nobel Prize in Physiology of Medicine in 1905. So what was the initial treatment for TB? So now, as we know, there is various drugs, and we give usually as a combination drug. So what was the treatment initially? So, so if you can see this, this is nothing but a technique of introducing pneumothorax, voluntarily introducing the pneumothorax in the patient by this technique is called plombage. So this was ancient technique in 1900s. They used to. Not sure. Okay, I'm sorry for that. So I hope my slides are visible now.
Yeah, slides are visible.
This was the one I was talking, Robert Koch. And the initial treatment was this. This is the technique of introducing pneumothorax. So they had by then understood that TB is infecting wherever there is the upper lobes, and because of which they started using this technique called plombage. And the easiest or the simplest procedure for TB was bed rest in horizontal position. And initially they discovered that sun rays are very good at sterilizing the patient. So for which various sanatoriums were built. That is, and other techniques like artificial pneumothorax, artificial pneumoperitoneum, thoracoplasty, that is, voluntarily they would remove certain part of the rib so that that part of the lung will not expand. So if anyone can answer, what was the first drug which was discovered for TB? Let me see how many of you are awake or listening till now. Anyone, any guesses? Streptomycin? Okay. One thing is there is a debate between streptomycin and your PAS. So in 1940, this is Jorgen Lehmann. He saw this. His friend, who was a pharmacologist, Frederick Burnham, had left in an envelope 1 milligram salicylic acid. The difference could stimulate oxygen uptake in bacteria by up to 100%. So this gave him an idea. So if this could be the treatment for or the cure for tuberculosis. So if salicylic acid can stimulate the uptake, so why not use any other thing similar to this for stimulating the uptake so that the mycobacterium stops reproducing. And with this was born the first drug, that is PAS. Again, the history says there is a conflict between whether PAS was the first drug or streptomycin. At the same time, Mr. Walkman, he was studying on the soil pathogens, that is, he was working on actinomycetes. He was looking for microbes in the soil which will prevent the growth of bacteria. And he had isolated one antibiotic from this, and that it was advertised first in 1944, that is streptomycin. And on November 20th, 1944, the Mayo Clinic had started the trial of this drug against the TB, and for which he has got Nobel Prize for the discovery of this drug. Coming to the landmarks of TB therapy, it was the first time they had conducted an RCT where they looked at comparison between streptomycin and PAS, and that is when the concept that you should never treat active tuberculosis with a single agent was born. 1952, isoniazid was introduced. Isoniazid was discovered and it was introduced, and the overall duration of the therapy was 24 months, which gave good cure in 90 to 95% of the patients. 1960s, there was discovery of various drugs, rifampicin, ethambutol, pyrazinamide. They also got to know that when they replaced ethambutol with PAS, the duration of therapy they could bring down to 18 months. 1970, they added rifampicin, and further this led to reduction in the therapy to 9 months. 1980s, pyrazinamide was added, and this was when the total duration to 6 months. This is what we know currently. In 2000s, they got to know that because the patient were on treatment for such long time, 6 months, so they wanted to increase the adherence. So they brought about the system of DOT, that is direct observation treatment, where they had 6-month regimen given thrice weekly throughout, or they had also given twice weekly, following a 2 weeks daily induction phase. By this time, the MDR TB had already started emerging. 2012, there was after a gap of almost 20 to 30 years, we had the first newer ATP anti-tubercular drug, that is delamanid and bedaquiline. And in 2010, it was the WHO had announced that thrice weekly regimen will be continuing, and that was the standard practice up to 2016. So from 24 months, the duration has reduced to 6 months, it's up to 2016. So we will be seeing the further course in later part of my slides. So by then they had understood the TB per se in a patient is divided into 4 hypothetical population. That is, some organisms are actively growing, some are slow or intermittently growing, and some of them survive easily in microaerobic condition, and some of the organisms lay completely dormant. And that is the reason multiple drug regimen, that is using multiple drugs to target these various populations were introduced. That is, so which of the following ATT is most active in the pus amongst the first line HRZD? Let's see, anyone, any answers? Okay, the answer is pyrazinamide. So whenever you look at the first line, the drug which is acting on rapidly multiplying population is your HR, that is rifampicin and isoniazid, and your streptomycin, which is bactericidal. The drug which is very effective in intracellular population and in acidic medium, and also slowly multiplying population is your pyrazinamide. Sterilizing effect is what is brought about by rifampicin and pyrazinamide. And rifampicin is one such drug which can act on multiple such population, including rapidly and intermittently multiplying population. And that is why we give this as a combination. So pyrazinamide is given usually only in the intensive phase, just because it will act on the slowly multiplying organism. So mechanism, I am sure all of you are familiar with it. I won't be going in detail in this because of the shortness of time. So rifampicin, as we know, it is RNA polymerase inhibitor. Pure fluoroquinolone DNA guidase inhibitor. Pyrazinamide acts in multiple mechanisms, and ethambutol and mycolic acid synthesis inhibitor are your isoniazid, ethionamide, etc. So these are the various actions. That is, most early bactericidal is your isoniazid, streptomycin. Sterilizing effect maximum seen with rifampicin, and prevention of resistance, emergence of resistance is mostly by your HR. So that is the reason in most of the regimens we always target that the patient should get rifampicin, because it has a maximum sterilizing effect and it will act on various the bacteria in various cycle of the cell division. So coming to the current guidelines for drug susceptible TB management. So there is standard treatment workflows which has been released in India, and so like extra-pulmonary TB, which was released just today. So these are very good go-to reference for management of TB, especially drug susceptible. So drug susceptible TB, the Indian government has not yet separately released for your pulmonary TB, and there is an older guidelines, and only the modification of the drug sensitive TB has been taken up. So 2016 onwards, the WHO revised that the thrice weekly regimen should be stopped and all the patients should get daily regimen. So that is the current practices, and all the various category systems has been abolished now. So irrespective of the patient, whether he is a relapse or a reinfection or previously treated infection, every patient will get the same therapy once the TB is diagnosed. That is, intensive phase, we have 2 months of HRZD, followed by continuation phase, we have HRE. And WHO mentions that in continuation phase, HR can be only HR can be given, but in India we have ethambutol. This is why, because in India we are seeing a lot of isoniazid monoresistance and a higher prevalence of HIV. So wherever WHO has mentioned that wherever the areas are having high isoniazid resistance or high HIV prevalence, better to add ethambutol in the continuation phase. So what is the most common form of TB? Obviously the pulmonary TB. So what is the most common form of extra-pulmonary TB? So TB, lymph node is the most common in India according to the NTEP. What is the most dangerous form of TB? So which has already been discussed, TB meningitis is one of the TBs which is associated with highest mortality, and we will have, that is why we need to keep a high degree of suspicion and treat it early. And what is the most common cause of unilateral pleural effusion in India? It is the TB. And that is why, though the diagnosis may not be established in most of the situation because the sensitivity of pleural fluid to detect by detection by CBNAT is quite low, most of the patients will be started on empiric TB regimen. And what are the most uncommon forms of TB? If at all, there is no single answer. So isolated hepatobiliary, pancreatic, ENT, or cutaneous or primary ocular TB. These are the uncommon forms of the TB. So when we look at the various sensitivity and specificity of various EPTB samples, why am I concentrating on EPTB? Pulmonary TB is relatively easy to diagnose, and I would say relatively most of the patients will be easily diagnosed, and even the CBNAT will be picking up and has very good sensitivity. But for EPTB, what are the limitations? The sensitivities, as you can see, is varying between different samples, and also the sample which we can get for extrapulmonary TB is very little, and repeated sampling cannot be done all the time. So CSF, if we can see, ZN staining very low sensitivity. Culture also obviously we are missing around 1/3 of the cases. NAT significantly has a better sensitivity of 70%. Similarly, your bone biopsy has a better sensitivity and specificity in the NAT. Urine has very low sensitivity even with the NAT. So even in the NAT, we have Dr. Rahul has enumerated the sensitivity again differs between expert and expert ultra. Expert ultra has a better sensitivity for CSF, lymph node, and pleural fluid. So that adult TB is the treatment is based on the various weight category. Before, the weight categories were only provided for the pediatric. Now we have weight category one for the adults, and it has to be based on the weight of the patient, and it is a fixed dose combination which is available. That is, we have the red strip that is containing HRZE, and we have the green strip which has HRE, and the number of tablets the patient has to take depends on the weight band. And always the patient will be under follow-up, and in the follow-up, if his weight is increasing by more than 5 kg and he is crossing the weight band, so maybe the patient was initially around 47 kg and he's become 52 kg, he has crossed the weight band, we need to increase the dose accordingly. So initially he may be taking 3 tablets, now we have to advise him to take 4 tablets. So coming to the pediatric TB, again there are various weight bands, and the dose also is almost similarly isoniazid up 7 to 15 mg per kg, maximum dose of 300, the samples in 10 to 20 mg per kg, maximum of 600. Here the important point is anyone who is weighing, the pediatric also, if the baby or the child is weighing more than 39 kg, you have to give the adult weight band dose. And here if you see, there are certain places where 1A, 2A is there. So that is he has to take 3 tablets of the pediatric group and 1 adult tablet. So again, the similar, if the weight is increasing and is crossing the weight band, you will have to give a higher dose. So coming to the various EPTB treatment, again, the primary regimen is similar in most of the situation. Only thing is the duration varies, especially in pulmonary TB, we can have a fixed 6-month duration. But in extrapulmonary TB, it will vary. And most of the situation, it is up to 12 months. So, and also if we are doing any modification in the ATT, we will have to give a longer duration. And depending upon the various adverse effects or when we are modifying, we'll have to change the duration accordingly. And always after the treatment, we'll have to follow up the patient also at the interval of 6 months, 12 months, 1.5 years, and up to 2 years. So here I have a case, a 75-year-old man with hypertension, RA, with IHD. He has presented to emergency department with sudden onset of breathlessness, and there is a history of fever, orthopnea, lower limb and facial swelling. There is history of weight loss. On examination, there is pericardial friction rub and muffled heart sound. On X-ray, you can see it is very evident. There is a cardiomegaly, and 2D echo was done, which confirms our suspicion. So whenever we are seeing a patient with a muffled heart sound and having all these features, we should think of pericardial effusion. So the investigations again, the primary investigation like X-ray, ECG, echocardiogram, cardiac enzymes, and pericardiocentesis should be done to find out the etiology of the pericardial effusion. Again, in Indian scenario, pericardial effusion, it can be mostly TB. So, but it has to be proven, microbiologically proven. Again, the sensitivity is not very high, but you can rely. So whenever you are suspecting pericardial effusion, you will go for echo plus minus CT thorax. If there is pericardial effusion, you do the pericardiocentesis and send the pericardial fluid for usual total count LDH, ADA, and AFB. So if the patient is having exudative picture and ADA is more than 40, it is more likely to be pericardial TB. You can start the patient on ATT. And whenever the patient is having HIV, we'll have to look for features of lymphoma or other viral pericarditis as well. So, and one more important thing is, apart from the ATT in pericardial effusion, it is needed that the patient be given steroids, and it should be given for up to 11 weeks. A tapering dose has to be given. This is to prevent, one, it is prevent the reaccumulation. Second is to reduce the incidence of constructive pericarditis, which can be the sequelae of the TB pericardial effusion. So next case, a patient, female patient, type 2 DM, previous history of cholelithiasis, cholelithiasis, for which she has undergone ERCP as well as biliary stenting. And now she is presenting to us with upper quadrant pain, reduced appetite, fever, and significant weight loss. On examination, there is pallor and hepatomegaly, raised TLC, and inflammatory markers were there. Again, USG was showing some multiple heterogeneous hypoechoic lesions and suspecting some tumors. The tumor markers were sent, which showed within normal range. CT scan showing, so this multiple hypoechoic lesions were nothing but multiple liver abscesses with necrotic abdominal lymphadenopathy. So whenever such situation arises, most commonly liver abscess, the patients are treated only on antibiotics and with the parasitic amoebic cover. So it is necessary that all these liver abscess patients, we need to send a sample even for the TB NAT, because here the history is quite significant. Fever, weight loss, etc. is already there. But always, all the liver abscesses are not just pyogenic or amoebic. There is increasing cases of TB liver abscesses as well. So the sample, whenever we are assessing, we need to send for the TB NAT. So coming to the various forms of the gastrointestinal TB, we have peritoneal TB, perianal TB, and isolated hepatobiliary TB. So all this, the investigation, typical ascitic tap you will be doing, sending for the cytology, looking at the SAG, that is serum albumin to albumin globulin ratio you have to look at, and ascitic ADA, if it is more than 39, it is more suggestive of ATT and TB. Gastrointestinal TB, the biopsy and imaging has to be done. And one more important thing is, most of these cases will be going to the surgery, and all of these, whenever they take out the sample will be going in formalin, and we will not have the microbiological diagnosis. So it is necessary that whenever you're suspecting TB, you need to send the sample in a normal saline. And any patient with EPTB will always have to rule out HIV as well as blood sugar test to rule out the diabetes or the diabetes. So HIV test is very important in EPTB patient. Next, this case was, I think, like similar case was discussed already by the Dr. Santanam. So a 35-year-old businessman coming to us with headache, fever, GTCS, with some irrelevant talks and delusions, initially consulted a psychiatrist where he started on olanzapine. When we asked There was some history of 1.5 fever with cough since 2 months and history of contact with TB in the workplace. And when you visit the chest X-ray, you can see this is the miliary mottling on the chest X-ray. So whenever we are thinking about a patient who is having chronic fever, cough, and presenting to us with meningitis, especially in India, we need to look at have a suspicion for TB meningitis, and the CSF showed picture is quite evident. Protein is quite high, 351, glucose is 59, and it was predominantly lymphocytic. So, and it is not necessary that all the patients will have lymphocytic pleocytosis from the beginning. In acute cases can also have neutrophilic predominant. We have seen in a case in ICU where we had neutrophilic predominant. So, in whenever we are taking a patient with meningitis, it is necessary that you take adequate history of the patient and look at, you have to send for the HIV test, which is very important again. CSF, CBNAT, the sensitivity is quite low for expert, but ultra has a very better sensitivity. So CSF, CBNAT has to be sent in the patients who have suspected TB meningitis. Also, if at all this because the sensitivity is low, you will have to look for any other foci, like the patient may have lymph node, the patient may have miliary mottling. So you can, if the patient can't expectorate the sputum, you can send gastric aspirate. So you will have to look at for other evidence of TB. An MRI was done, and MRI was suggestive of leptomeningeal enhancement in the patient systems. These scoring systems have already been discussed with by Dr. Santanam, the TWAIT score and the Lancet score. So these are very good scores, and you can use it for picking up or early diagnosis of TB and when we should be suspecting TB meningitis. So this is given by the standard workflow which has been given by the NPEP program. Again, these are nothing but the various parameters which has been discussed: more than 5 days of symptoms, WBC, so CSF sugars less than 50% lymphocytic, and neuroimaging showing basal exudates, hydrocephalus, infarct, and tuberculoma. So if there are evidence of TB is the third criteria. Second criteria is HIV infection, severe malnutrition, recent contact with TB. If more than two criteria is met, we should be starting empirically on ATT because the mortality is quite high for TB meningitis. But you shouldn't stop. That doesn't mean you stop evaluating. You should continue your evaluation, start the patient on the ATT. The issues with the TB meningitis is with the treatment. So it is difficult to diagnose. But once you arrive at the diagnosis, also the treatment is quite difficult. Though the NTP easily mentions that the patient should get HRZD and continuation phase HRE for 10 up to, so the treatment is up to 12 months. 12, it can extend up to 18 months. And another thing is the patient should be put on steroids. So the indications for steroid in TB patients, that is mostly in EPTB. First was, as I had discussed already, EPTB, TB pericardial effusion. This is the second indication, that is TB meningitis. These are the absolute indications for the steroid. But other indications could be whenever you're suspecting TB iris or paradoxical reaction, or if the patients which are having the TB lymph node not responding. So it can be used, but absolute indications are these two. And always we have to give the dosage is dexamethasone 0.4 mg per kg per day divided dose, and we have to taper the dose slowly over 8 to 12 weeks. And when we look at the penetration, if you see isoniazid, pyrazinamide, and linezolid has a maximum. So the major drug of the TB ATT, which is rifampicin, if you see the CSF penetration is very, very low, 5 to 25% only. So that is why there are various studies which are using, looking at the various modification of the ATT in CNS TB. One is the high dose rifampicin. So there have been various studies, including an Indonesian study where they have looked at high dose, that is up to, so usual dose is 10 mg per kg. The high dose which we are looking at is as high as 35 mg per kg. So they have observed that there is early bactericidal and faster clearance when we use and better attainment of the drug levels when we use higher dose. And one more thing they're considering is addition of fluoroquinolone. So this one study has showed that there was significant survival benefit when the patient received levofloxacin in the initial period, but another study had showed that there was no survival benefit. Another thing is addition of linezolid. So as I have shown before, linezolid and fluoroquinolone has excellent penetration into the CSF, and that is why we can consider this. And this has been again evaluated in various studies. This is especially studied in HIV TB meningitis, where recent one study also was published where there were good outcomes. And one more thing is addition of aspirin. So TB meningitis associated with various vasculitic infarcts. So this aspirin has anti-inflammatory, anti-thrombotic effect. And even a study done in India showed that there was giving aspirin was associated with low 3-month mortality and lower incidence of stroke. And other thing which we need to be worried in TB meningitis is TB iris or the paradoxical reaction. So various, that is one of the reasons for steroid use is this to prevent this. Other NSAID like aspirin can be used. If at all the patient is not responding, thalidomide, montelukast, and VEGF inhibitors have been tried. So the last case, a 25-year-old female with complaints of neck swelling, she has come to us because it is causing cosmetic disturbance. So there is no history of fever, TB, or weight loss. On examination, these were multiple in the matted firm lymph nodes around 1.5 centimeters, and FNAC was suggestive of necrotizing granulomatous inflammation. CBNAT was sent and it was MTB positive and was started on HRZT. She was all fine. Now she has come back after 3 months with increasing size of the swelling. Again, this case was similar case was discussed by Dr. Ramya. So whenever we are looking at TB, lymph node TB, it is very one thing is the patient, the sample you can easily get, FNAC or biopsy you can do. You can arrive at the diagnosis also. But the issues with TB lymph node is lymphadenitis is this recurrence. This is we have seen in multiple patients will come back with the complaints that the swelling is increasing. So what do we have to do with that? So after 3 months, we will have to, when if at all there is a recurrence, you have to look at whether there is associated with signs of inflammation or constitutional symptoms are persistent. And first thing is you will always have to look back and see if this was a confirmed TB. So most of the most of the clinicians will just on the suspicion of TB will have started, and it would very well be NTM. So first you'll have to find out whether there is any alternate explanation. If no alternate explanation, check the old culture report. And if at all the patient is having initially only FNAC was done, now you can try to remove the node, do the complete biopsy, and look for the further drug resistance pattern. So if it is again suggestive of susceptible TB, you will have to go for TDM, and if when the drug levels are okay, you will have to look at paradoxical worsening. So if it is just a cosmetic issue, just removal of the reassurance and the removal of the node can be done. Next case, patient 35-year-old CLD, HPA-CG positive, presented with left-sided chest pain and difficulty in breathing. On examination, there is reduced movement on the left side and auscultation, decreased air entry. So this was a chest X-ray of the patient. So what is it? So this is typical of your pleural effusion, left-sided, unilateral pleural effusion. Pleural tap was done. It was exudative and was sent for AFB and CBNAT, unfortunately, which was negative. So whenever we are looking at pleural effusion, most of the clinicians miss to send this. So around 30 to 40% of the patients with pleural effusion will have sputum positive TB. So it's not that only pleural fluid sample should be sent for the diagnosis. You will also have to send the sputum sample for the diagnosis. And and there are higher chances that your sputum can be positive than the pleural fluid. And whenever we are looking at suspecting pleural TB, we will have to send for cytology and as well as ADA. So whenever a patient is having exudative protein with a pleural fluid glucose of more than 60 and which is typically lymphocytic, and ADA is more than 40, it is almost most 80%, 80 to 90% of the time is suggestive of TB, pleural effusion, and the patient can be initiated on ATT. So if the patient is having pleural fluid is having ADA of more than 70, it is almost certain that it is certain that it could is definitely pleural TB. So you will have to initiate the anti-tubercular drug, and if there is no response, the ideal sample for pleural effusion is the pleural biopsy. So if the patient is not having any response or the effusion is recurrent, ideally you will have to go for pleural biopsy, and will be treating based on the microbiology of that. Female genital organ TB, I will not be going into detail. So this one important thing is when we will be suspecting, the most common complaint is infertility. So whenever a patient is having primary infertility or secondary infertility, first and foremost, TB is the thing which comes to our mind. And most often the patient will not have any other foci. So clinical history and physical examination. So if you're finding any nodes, you can biopsy that. Or if at all, if any other foci is found, you can do the biopsy, or sputum. If the X-ray is abnormal, you can send the sputum sample. Important thing here is the NTP has mentioned that ensure blood should not be used for NAT. As we all know, blood sample, stool sample, and urine sample are ideally not recommended for CBNAT, but there are various studies which have used this sample and have got good results. Because the blood contains certain inhibitors of PCR, and as we all know, the NAT also is based on PCR. That is why menstrual blood should not be used. Ideally, the biopsy sample after doing the laparoscopy, that sample should be sent for diagnosis of TB. Genitourinary TB, first thing should be suspected when the patient is having sterile pyuria, which is not responding to various courses of antibiotic, and there is history of fever, weight loss, night sweats. Ideally, the patient, so important thing here to remember is urine sample which is sent for CBNAT. It's not, urine has a very low load of TB bacilli. So what you should do is you have to send multiple sample, at least 3 days. So 3 to 5 days, early morning sample has to be sent. That is the first void should be sent repeatedly to prove a genitourinary TB, and NAT has a comparatively better sensitivity compared to other diagnostic modalities. So ocular TB, I have just put this slide just to, so primary ocular TB is quite rare. It can be in form of uveitis, vasculitis, choroiditis. So why is it involving more choroid? Choroid is where the oxygen saturation is low. So that is why one important thing is most of the references we get from the hospital is a patient suspected to have uveitis and is having MAN2 positive. So please start the on ATT. So is it necessary? So whenever you are suspecting ocular tuberculosis, if it is a choroid nodule or a granuloma, it is highly suspicious. But if it is just recurrent uveitis, vasculitis, you will have to rule out other systemic illnesses. Also look for extraocular TB sites, like by doing CCT of chest, abdomen, or if there are lymph nodes, do the FNAC. If the systemic illness is ruled out, extraocular TB is absent, there is no need to start the patient on ATT, and the patient can be managed with just steroid and immunosuppressive agents. So most of the often this uveitis or vasculitis or choroiditis we are seeing, maybe the MAN2 is positive, the TB could have been there. So these are the effect of the antigenic response to the TB bacilli, and not necessarily because the TB is present. That is why just steroids or immunosuppressive agent is sufficient. Musculoskeletal TB, your port spine is the most common form, and port spine or psoas abscess, the patient will come with persistent low back pain or neurological deficit. The patient will be initially treated by the orthopedician. Again, for the key to diagnosis is biopsy, sample, send for CB-NAT. So most of these patients would have received empiric ATT, and as we know nowadays there is high increasing resistance. So that is why we need to have a microbiological proof of TB as well as the drug susceptibility. So what's new in when we are looking at drug susceptible TB? I had mentioned that all of these patients HRZD for 6 months is the standard regimen. So what's new is this was an article recently published in NEJM, 4-month rifampicin regimen with or without moxifloxacin for TB. So here what they have seen is rifampicin moxifloxacin combination therapy was associated with it was non-inferior to the standard therapy, as well as one more thing is they have evaluated shorter treatment for non-severe TB in African and Indian children. Again, they have seen that instead of giving the 6-month therapy, a 4-month therapy of same HRZD plus HRE or HR can to 4 months of HR can be given instead of the 6 months. So based on this, the WHO has updated its guideline, saying in the patient's age between 12 years and older, and the patient is having drug susceptible pulmonary TB, we can give 4 months therapy, that is 2 months of isoniazid, pyrazinamide, moxifloxacin, and pyrazinamide, and 2 months of HPM. In patients, in children and adolescents between 3 months to 16 years, if there is no evidence of severe TB, or if there is no evidence of MDR TB, we can give 4 months therapy of 2 HRZD plus 2 HR. So these are the 2 new updates in the WHO guideline. This is currently not yet recommended by the NTP. So what lies in the future? We are looking at reduced duration of therapy. We are looking at alternative therapy. And obviously we have various newer TB vaccines, which is there. So the Truncate trial, which was released recently, which I have also discussed in my recent talk in my YouTube channel. So treatment strategy for rifampicin susceptible TB, here they have looked at giving, instead of just HRZD, they have looked at high dose rifampicin plus same HRZD-L. So 5 drugs instead of the usual 4 drugs with a high dose rifampicin they have evaluated, and they have found that it was non-inferior. So this, and the important thing is the reduced duration. That is, instead of giving the patient 6 months of therapy, you are giving just 24 weeks of the 8 weeks of the therapy. And other things which are expected is RIPA short, where they are looking at 4 months of HR, that is 2 months of HR plus HRZD with a high dose rifampicin plus 2 months of HR with again high dose, that is 1200 mg to 800 mg. Then we have Simplicity TB, which is looking at bedaquiline based regimen for DSTB with bedaquiline, pretionamide, moxifloxacin, and pyrazinamide, that is 4 months therapy. And this one, they are including both drug susceptible as well as drug resistant. So they are looking at a treatment irrespective of the resistant status. And then we have this PRS regimen, where they are looked at 4 months clofazimine, ethambutol, prothionamide, and high dose pyrazinamide. This one they have published the results. And again, not all trials will yielding good results. Here they have seen that it was inferior and it was associated with higher incidence of hepatitis. Last topic, drug resistant TB. This is the guidelines, that is PMDT, that is programmatic management of drug resistant TB in India. So first and foremost, the definition. So monoresistant means drug resistant to only one of the first line drugs. Isoniazid monoresistant is resistant only to the isoniazid but sensitive to others. MDR TB is resistant to first line, that is isoniazid and rifampicin. Pre-XDR TB is MDR TB, that is isoniazid and rifampicin resistant, along with fluoroquinolone resistant is your pre-XDR, and that is the current change in the definition. Then we have XDR TB, where MDR, that is isoniazid resistant, rifampicin resistant, fluoroquinolone resistant, plus another drug in the group A. So what are these groups? So this group has been rearranged. So the group A has levoflox, that is fluoroquinolone, bedaquiline, and linezolid. Group B has clofazimine, cycloserine, and cycloserine. Group C has various drugs. So if you see, your group C has your injectable drug. So now we are moving. Initially for MDR TB, we were looking at only injectable, and the HDR definition was resistant to your second line injectable drugs. That has been removed now. Injectable drugs are like almost never used currently, except for in scenarios where the patient is having adverse reaction to the other drugs, and when we can't give group A or group B. So mostly the regimen will compose of all the three drugs from group A, one or both of group B, that is clofazimine or cycloserine. And if the combination is not possible, then one of the drug of the group C is involved, and they have made the various regimen. So the treatment algorithm for MDR TB. So whenever rifampicin, so Sibinan is detecting rifampicin resistant. And one more important thing, it is not whenever you're sending a sample for CBNAT, we have to send it in a sample pair, at least one pair, that is 2 samples has to be sent. So the lab has to use one sample for testing the CBNAT, and in case the resistance is reported, the second one has to be subjected for the first line LPA, second line LPA, and your liquid cultured DST. So after during when we are awaiting this report, you will have to do the pre-treatment evaluation for the patient. And there is a Nixchai app. If many of you don't know, there is a Nixchai app where these reports will be uploaded if the patient, if the sample is in the NTEP center. So you will always have to check the Nixchai app for the LPA report, and based on that, you can give the treatment. First and foremost, you will need to look at resistance to other drugs. So if there is no additional resistance, that is only rifampicin resistant, there is no additional resistance detected, or if the patient is having only isoniazid resistance, that is again isoniazid resistance, as Dr. Rahul has enumerated, it can be due to resistance in LPA, CADG or INHA. So there is only one of these, that is CADG or INHA, then we can go for shorter bedaquiline based regimen. And if the patient is having only isoniazid resistance, we can go for the isoniazid mono resistant algorithm. If the patient is not falling into any of these two categories, we will have to go for longer oral regimen. So now even for XDR TB, we have only oral options which is available. If the patient can't take the oral, then only we are going to the injectable, including the injectable. So the inclusion criteria for oral bedaquiline regimen is first and foremost rifampicin resistant. Then if there is H resistance, but only due to single mutation, and no fluoroquinolone resistance are the inclusion criteria. Exclusion criteria, so where all we can't use children under 5 years weighing less than 15 kg, it can't be used. If there is any exposure to the bedaquiline based bedaquiline or linezolid or the regimen for more than 1 month, if the patient is having extensive TB, severe extrapulmonary TB, pregnant ladies and lactating females should be not put on the shorter oral bedaquiline regimen. So what is the regimen? So the regimen is for duration of 9 to 11 months. So 4 to 6 months of bedaquiline, 4 to 6 months of the intensive phase followed by 5 months. In that, bedaquiline is given for 6 months only. And other drugs like levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose isoniazid, ethionamide. So initial phase will have your 7 drugs followed by 5 months of levoflox, clofazimine, pyrazinamide, and your ethambutol. So points to remember is from start till 4 months, the patient will receive all these 7 drugs. From the 5th month, if you are not extending the IP, that is intensive phase, you will be giving bedaquiline, levoflox, clofazimine, pyrazinamide, and ethambutol. And after 7th month to 9 months, you're going to give levoflox, clofazimine, pyrazinamide, and ethambutol. So if it is extended, all the 3 drugs, that is bedaquiline, high dose, rifampicin, and ethiomide, are stopped together. So obviously, whenever the patient is on such drugs, you'll have to monitor. So what are the side effects of the various regimen? I'll be discussing in further slides. These are the various doses. Again, it is based on weight-based band. And whenever a patient is on bedaquiline, you need to always look at the various drug interactions. So there is a lot of interaction with bedaquiline, and you can't remember. Obviously, it is impossible to remember the important ones, including the patient can't be on panto or omes. With the patient, mostly all the patients who are on ATT will have this gastritis, and patient can be put on panto or omes. It should be avoided, and instead should be put on ranitidine, Rantac. Patient can have emesis, so again, Ondan is contraindicated. So such we need to remember, or whenever in doubt, you will have to look at the drug interaction. So next, coming to the isoniazid monoresistant. So it is very simple. So instead of HRZD, you give LRZD. That is levoflox instead of you are substituting for your isoniazid, and the duration is 6 to 9 months. So again, whenever you can't give any drugs. So if you can't give levofloxacin, give moxi. If both moxi or pyrazinamide can't be used, you can use linezolid. If you can't use linezolid, we can give clofazimine or cycloserine. So all these replacement sequences also has been mentioned in the NTP guidelines. So if the patient can't be given any of this, and the patient, you have to give the longer oral MDR regimen. It is 18 to 20 months of 5 drugs: levoflox, bedaquiline, linezolid, clofazimine, and cycloserine. Bedaquiline is given for 6 months. So if someone asks you what is the most toxic drug in the ATT, it's your linezolid. Here, what the dose of linezolid you are giving is a very high dose, 1200 mg per day, initially for 3 months. Then you will be reducing based on, so linezolid induce toxicity like anemia, thrombocytopenia. If the patient is developing, you need to reduce and stop. So these are the various drug reactions. So important ones which you need to remember: QT prolongation by bedaquiline, fluoroquinolone, clofazimine. Hepatitis. So the most hepatotoxic is pyrazinamide, ethionamide, PAS, and bedaquiline. Seizures causing is your isoniazid, fluoroquinolone, cycloserine. Nephrotoxic, obviously, amikacin. So again, these are the various adverse reactions you need to look into the patient. So most common adverse reaction which we have seen is the rash or anaphylaxis, and it can be caused by any drug. The most common ones has already been discussed with Dr. Santanami earlier. So what lies in the future? The shorter regimen and better regimen. So we have one paper which was recently published in NEBM, 24-week all oral regimen for rifampicin resistant tuberculosis. That is, we already had BPAL, which was on an experimental basis. Here they looked at BPAL-M. So instead of giving a longer duration, so what we were looking at was almost 20 to 24 months of therapy. Now they have reduced it to trying to reduce it to 24 weeks. That is nothing but 8 months of therapy. That is by giving BPAL-M. So there was a significant difference. That is, it was associated with lesser percentage of patients having the relapses, and even the adverse effect profile was comparatively better in this group. And the most common side effects which we are expected to see in BPAL-M is obviously the hepatitis as well as QT prolongation, which was seen in almost like only 1 patient had QT prolongation and only 3 patients had the hepatitis. So summarizing, so whenever drug sensitive TB, the treatment of choice is your 2 HRZD plus 4 HRE. H monoresistant, just replace H with L, that is LRZD. Shorter or oral MDR or bedaquiline based regimen is your 7 drugs plus 5 drugs, that is 4 to 6 months of bedaquiline, levofloxacin, clofazimine, high dose isoniazid, ethambutol, followed by levoclofazimine, paravenamide, and ethambutol. All oral longer MDR regimen is 5 drugs, bedaquiline, levofloxacin, linezolid, clofazimine, cycloserine for 18 to 20 months, and the one which are for XDR or experimental therapy is BPAL. They are looking for initiating BPAL in the NTEP, but currently there is no recommendation as such. So I would like to use this opportunity to bring to notice we are having IDCON 2023. So the 22 grand sections, and again we are having this year this IDCON 23, where we again will be discussing case-based discussion on drug-resistant bugs. So the registration is open and it is on May 6th. Also, we have ASPICON 2023 this year at AIMS Jodhpur in collaboration with the Society of Antimicrobial Stewardship Practices (SASP) from September 29 to October 1st. So, as a part of ASPICON, this is a national conference. So, we have a national quiz competition. The preliminary round is on April 7. So this is done in the various INIs and the centers of SASP. So in case you are a state medical college, you can coordinate with the local INI which is available, and you for the participation purpose. So thank you. I can take some questions before we start the quiz. Any questions? Okay, I think all of you are very tired, so we will move forward to the last part, that is the TB quiz. So stay tuned for that. We have great prizes for the winner. And again, this will be on the VWorks platform. So let me share that now. Sorry for the technical glitch. So we'll start with the quiz. I hope everyone is ready. So I'm sharing the screen. I hope it is visible. So please join this VWorks. So either you can click vworks.app in Google search and type in the ID, or just scan through your Google scanner or any scanner. So just scan the code. You'll be joining this quiz. So please let me know. So has everyone joined?
So corporators with also meeting. The girl सांगेगा सो फाइनेंस का क्या करो चलो corporate पैसा मांगे
और कौन जाके ससुर बच्चे
अभी तो कोई टाइम नहीं
कुछ दरकार नहीं सुबह उठते जल्दी बच्चे
और ऊपर से रसों सीनियर के सामने
हाँ mundo bawah asal ada pikir aku
I'm extremely sorry for the delay because of the technical glitch. So I hope all of you have joined this. So the rules are pretty simple. We walk online. There is 30 seconds to answer. Please don't cheat. And there is attractive prize for the winner. So I hope all of you have joined this platform. So can we start now without any further ado? Shall we start? Okay. So we'll be starting. First question. Which of the following antimicrobial is not a part of drug cocktail used in visit to prevent contamination? So you would have heard the mnemonic Fanta. So what is not a component of this Fanta? So all of you respond. Okay, there are 12 participants. I hope who have not joined, please join this. So if you have not yet opened, please open the Zwork.app and this is the ID. You can put in the ID and then respond. Okay. Let's end the poll here. So most of you have got correct. It is a Aditya. My mistake. You cannot get understand. So next question, 54. I will just start the poll once I finish reading the question so that it is easier for you to answer. 54 years with 3-month history of hemoptysis, approximately 50 ml, had a remote history of pulmonary tuberculosis. He had an episode of massive hemoptysis on the 2nd of pulmonary and bronchial. As shown, it shows a large pulmonary aneurysm. The patient underwent successful embolization. However, the hemoptysis resolved only after subsequent embolization of the bronchial artery. So, this thing, what you're seeing, what type of aneurysm is it? So, this is a very common name which you will be associating this aneurysm with whenever a patient of TB is presenting with massive hemoptysis that is due to the erosion of the bronchial artery, and the aneurysm has a particular name. So what is the name of this aneurysm? So again, I request in case you're not able to respond, please join this ID so that you can participate in the list. So let's end it here. So most of you have got a 50% transmission. So this type of aneurysm is called diastole aneurysm. And unless you do the embolization bronchial, then most likely it's not going to stop. So this is so in which part of the gene export MTB cartridge does the PCR amplification process take place? Sorry. So question number 3. In which part does it PCR amplification take place? So is it 1, 2, or 3? 1, 2, 3, and 4, 4 and 5. So it will not. So which part does it take place? So have given the clue with this question. So I hope I get 100% correct answer in this. Let's send it here. Okay. So 3. So it is very evident in this picture as well. So it is the 3rd place, which part where the PCR actually takes place. So next question, grading scale of 3+ fluorescence staining for Mycobacterium tuberculosis under 200 that is 3+ in GLI. As per the GLI value is more than 250 FB, more than 25 FB in 1 case, more than 10, more than 100. This is according to the GLI. This year. Okay. None of you got it correct. So this is again GLI is more than 250
10
in
as
1.
3 plus is more than
So
10.
I hope I get 100% answer. Correct answer in this truncated TB trial. Compared what? Which of the following? Truncated. So BPAL versus standard of care in LDR-TB. HRZEL 8 weeks versus standard of care in LDR-TB. HRZDL, that is linezolid with the 5 drugs, 8 in DSTB, DPAL-M versus standard of care in DSTB. So I guess you guys know that Sanket TB is in DSTB where it compared the 5 drugs, that is HRZDL, A2X versus standard of. So at the end of 5 questions, let's look at the leaderboard. So reading is first is Anita Ram, ATP UG, Dr. Shubhangi, Nita. Next question. All of the following was QT prolongation except.
Prolongation.
So the is except, it's not all. Which of it will not cause QT prolongation? Let's send it there. Oh, I have surprising answers. So, Bedaquiline, sulfonylurea, clofazimine are notorious because QT prolongation Delamane is the one present cause. So, which of the following causes suicidal ideation in the ATP drug? Rifampicin, nitrosamine, paracetamol, dexamethasone. Oceanomide, most of you got it correct. It's oceanomide. Even among the first line, apart from oceanomide, I think that also cost that more with oceanomide. Shorter oral TB regimen consists of. That question will not be considered. We'll move into this question. Exclusion criteria for shorter bedaquiline based regimen are all except. The exclusion criteria except which of it is the inclusion criteria? As simple as that. Accept it, right? So children more than 15 years you can do. So less than 5 years and more less than 15 kg is the exclusion criteria. More than 15 years children definitely can be given. So a 25-year female patient detected to have MTB symptom sample for with the rifampicin resistance. First line LPA shows resistance to a high level hyaluronic acid. Second line LPA is awaited. What would you like to start the patient on? So whether we'll wait for the second line LPA, start HRZD, start LRZD, start oral, shorter oral bedaquiline based regimen, none of the other. Let's stop here. LRZD. Yes. So if you can see, the patient had sputum sample with rifampicin resistance detected with the isoniazid resistance. So the patient we should be starting on shorter oral bedaquiline based regimen. Again, you will have to wait for the second line LPA report. Till then, you can start on shorter oral bedaquiline. Then, if at all other resistance is also there, you will have to shift to the longer oral based regimen. Okay, this arrow is marked wrong. It is shorter oral bedaquiline based regimen. Optic neuritis is caused by all of it except This year. And so it's very known fact that ethambutol is causes of neuritis. Along with that, what all causes nimble can cause ethambutyramide can cause clofazimine can cause pyrazinamide is one which does not cause optic neuritis. So at the end of 10 questions, we have our leader APP. I hope you comment the full name here. So if I'm reading your name wrong, I'm extremely sorry. So next question, which of the scoring system is not used for TBM diagnosis? So this Dr. Santana might discuss. So I hope I get 100% correct answer in this. Okay, mixed response. So CMC value score is so all of Maria's score is nothing but another name for this. Lancet score, trade score, and TBM score are used for diagnosis, whereas CMC value score is not used for TBM diagnosis. It is used for the staging. Next question, WHO recommendation for use of gene expert for TB is not applicable for which of the following samples? All of you, most of you have voted correct. So the WHO doesn't recommend stool, blood, or urine, but currently the WHO has released one new guideline for diagnosis, especially in HIV individual. Blood can be used, but in general it is not applicable, and stool, blood, and urine are not the recommended samples for the genes. So MTB complex includes all of the following except. So obviously it is just mycobacterium tuberculosis. Apart from that, which are they? And which is the one which is not there, which is not a constituent of MTBC complex. So this Dr. Rahul had discussed. If you don't know anything, also mycobacterium cancer is a part of MTBC, so obviously it's not a part of MTB complex. Last but one question, which of the following is false about LPA according to the MTP?
ପଢୁଛି
Let's start here. So according to NTP, the LPA can't be done on clear negative, because that is done only on positive cases. And it has relatively less value in HIV and EPTB because the chances of the load of organism in EPTB is quite low.
and within 2 days it will
So interpret this LPA report. This pink one is the one which you need to interpret. So what is the inference if you are seeing LPA stress like this? Last question. Yes, so if you can see, so TB detected with all the wild strains, WC wild strain positive, but no mutant strain. So this is obviously entity detected with no second line drug resistance. So let's look at the results now. Ready for the results? Okay, we have the clear winner, ATP UG. If you can unmute yourself and talk. Congratulations. The runner-up is Ambati Mrudula. I hope I'm pronouncing your name correct. Who is the ATP UG?
Hello, hello.
Okay.
Hello, I'm Dr. Vishal from SGPGI.
Okay. Congratulations, Vishal. What's
Thank
the
you.
meaning of ATP UG? By the way?
Actually, my surname is in reverse order is ATPUG. So I usually give that name in my surname is
Okay.
Gupta. So in reverse order it is ATPUG.
Okay. Anyway, congratulations. So you're the winner of this. So you'll
Thank
be receiving, please leave your email ID. So you'll be receiving cash prize as well as free registration to IDCon 2023. So the runner-up Ambati Nudila will get free registration to IDCon 2023. So please leave your contact details in the chat, your name, your affiliation with the institute, as well as the contact number and the email ID. Thank you all for participating, and I'm really sorry for the various technical glitches, and I know we are quite late, and I thank you all for such being enthusiastic viewers. I hope we have done justice to the time taken. So we'll be sharing the feedback form. Please do fill the feedback form so that we know where we are lacking. I know one feedback will be definitely the internet issues and the various technical glitches. So I will try to reduce it as far as possible. In case you want to view this session again, it is available on my YouTube channel. Thank you. So I'll be sharing the feedback form in the chat section as well as by the email ID. Please do find time and give the honest feedback to us. Thank you. Have a good day. Sorry. Good night.